and welcome to today's episode of Talk on Things and Stuff. Now, if you've been following the channel, you know that periodically we have been covering the political debates around the issue of gender-affirming care for children with gender dysphoria. Some people frame this debate and discussion as healthcare for trans kids. We're trying to cut through some of the ideological jargon and describe it in clinical terms as we approach this issue. If you've been paying attention to the news, then you'll know that last week there was a Congressional Subcommittee hearing on a particular bill that had a very important funding aspect to pediatric children's hospitals that train residents and fellows, future pediatricians, which turned on the question of whether or not those hospitals offered affirming care in the form of surgeries or hormones given to children. And the text of this proposed amendment said that if any of the hospitals do offer any of these things, they would not be eligible for congressional funding, which is really the lifeblood of how those hospitals can hold trainees and of doctors. So as we frequently try to do, we try to get somebody with a little bit of background perspective on to review and provide some commentary for this. And today we have Dr. Julia Mason, who I will introduce now.
Hello.
Dr. Mason, how are you doing?
Doing okay. Hi, thanks for having me.
Now, if you're not familiar with Dr. Mason's work, you'll see her in a number of interviews, discussions, and published articles on the issue of healthcare for children experiencing gender dysphoria. And she kind of represents a dissenting voice in the academic world of pediatricians. If you follow this issue, you know that the American Academy of Pediatricians has come out kind of in support of gender-affirming care, but this seems to have been done in an environment of activism, which silences voices of dissent. And Dr. Mason kind of got pulled into that debate and discussion because of an experience with a patient. Is that right?
Well, multiple patients, actually. So, yeah, I got involved in the gender crazy back in 2018. I had my first transgender patient prior to that, probably 2016. But the first one didn't disturb me. It seemed like what I had heard about. It seemed like what I had read about in books. It was a natal female, and she was one of twins. And she said ever since she was 2 or 3, she always felt like there'd been a terrible mistake, and she was actually a boy, to the point where people said, well, if you're a boy, then where's your penis? And she happened to be one of those kids where the belly button stuck out. So she would point at like her little protruding belly button and say, there, that's my penis, and that's adorable, you know. And so she came in saying, you know, I was born a girl, but I'm actually a boy. I want to transition to be male, and told me the story. And I'm like, oh, that's a thing. Yeah, transgender. I've heard of that. Yeah, there's a clinic at the Children's Hospital. I can refer you to the clinic, and they will take care of you. And then she came back to our clinic, and she's like, oh my God, testosterone is a shot. I hate needles. I hate shots. And I was like, that's okay. Just come on in, and we'll administer the medicine. We won't get paid for it, but just bring it in and we'll administer it to you. And we administered it to them a couple of times. And then we taught his grandmother to give the shots, and that stopped. But I kept seeing this patient because this patient had ADHD. Mm-hmm. And so what I saw was masculinization happening, but like almost arrested development in terms of the tasks of adolescent. Mm-hmm. Didn't go to college, didn't learn a trade, didn't move on, didn't do the hard stuff. Like adolescence is a time to do hard things to set yourself up for the rest of your life. And this person really wasn't doing that. And then that happened again and again. And I was beginning to realize that every single kid who went to the gender clinic was being affirmed. Mm-hmm. And this was in 2018, and that was the year the AAP came out with the statement saying that the only appropriate response to any child who expresses discomfort with their natal sex is to be affirming. You know, they're like, there are kids who have gender dysphoria, and there are a few things you could do. You could try to talk them out of that, and that's evil and wrong. That's conversion therapy.
Now, yeah.
You could do watchful waiting, which was pretty much the standard of care prior to the AAP making the statement. And they're like, but that is also terrible and wrong. The only good thing that you can do is to affirm the patient's cross-sex gender identity, and you give puberty blockers, and then you give cross-sex hormones, and then you do surgeries. And the rest of it was just sort of a description of that.
And as I've heard you describe this before, this is where your character is a curious physician who doesn't just believe what is told you because it comes from an authority, but you want to understand it. You want to understand the evidence behind it. You want to make sure it matches this concept of evidence-based medicine, which is a guiding ethic for principled physicians. And things just weren't adding up, and down the rabbit hole you went.
It all started to fall apart. I mean, the first thing that really caught my eye was when everybody, from the endocrinology fellow to the endocrine, the endocrine attending, to the trans woman who led a local trans youth group called Transactive, they all told me that 99+% of kids who are put on puberty blockers go on to the cross-sex hormones and the surgeries and all the rest. And they said it like it was a good thing. They said it like, see, the kids, they just know. Like, every single kid we give puberty blockers, look at that. They all end up to be trans. Wow, who'd have thunk it? And I'm like, okay, 99% of 12-year-olds don't hold on to the idea of what they're going to be for Halloween over a period of 3 months. So no, the fact that 99% of kids persist in the cross-gender identification tells me that puberty blockers are not this harmless, reversible pause that you're telling me it is. It's just telling me that those puberty blockers are locking something in that could have been a temporary cross-sex identification.
Yeah, and it's that one point which landed like a bombshell to the UK researchers involved at the Tavistock when Polly Carmichael made that announcement, that first disclosure of their early experience in 2016. And that bombshell kind of just totally changed the perspective of a lot of those clinicians, and you experienced it in your own way there. But we're going to get to that because all of these different threads of the ideological infusion of these gender ideology principles into medical practice is on display in this congressional subcommittee hearing. And so I want to go ahead and move into that. But before we do that, let's go ahead and listen to the sponsor of the most critical amendment talk about how he frames the issue and their kind of approach to how this discussion starts, if that sounds good. So this is Representative Dan Crenshaw from Texas, who in the midst of this debate is finally given an opportunity to lay out his argument. And let's take a listen to that. Add it to our stream here.
The chair now recognizes Mr. Crenshaw from Texas for 5 minutes.
Thank you, Mr. Chairman. I first want to thank my friend, Representative Schreier, for her great bipartisan work on the direct primary care bill that we've been working on. It's look, there's a lot of things we can agree on, and this is certainly one of them. And this is a small step in the right direction. I'm really excited that we're gonna get this through. But now there are some things we disagree on here, and that's what we've been talking about a lot in this hearing. So let's shift focus to the giant elephant in the room. And this is the reauthorization for the Children's Hospital's GME funding. And yes, it's true. This is my bill. And what it does is it withholds funding from these hospitals if they engage in what they call gender affirmation therapy, these physical changes to a child's physiology, permanently disfiguring them through either puberty blockers or even surgical modifications. Now, look, I understand that the other side of the argument here believes they are on the side of compassion, and maybe that's a sincerely held belief. It is just as true that I believe we are on the side of compassion. I think it is indeed compassionate to stop kids from being permanently physically altered based on little to no evidence that it will improve their underlying mental condition. Now, why is this controversial? That's actually beyond me. Not too long ago, I think we all agreed that performing double mastectomies on a 12-year-old girl was wrong. Now it's become a political movement where radical activists have bullied mainstream medical associations and members of Congress into repeating this propaganda. Now, it should be noted that in the public, this subject is actually not very controversial. In fact, a recent poll just last month by the Washington Post showed that 68% of Americans opposed using puberty blockers on children. That's just a question about puberty blockers. Imagine if the question had been about castration or surgical interventions. So you've got to convince me that 70% of Americans are just a bunch of fools that refuse to accept the so-called science. Or maybe, like, I have another theory. Maybe they have a very baseline understanding of ethics and common sense, which tells us that maybe, just maybe, it's a bad idea to submit children to permanent life-altering medical interventions based solely on a temporary ideation about their gender. Gender affirmation is not science, and there's no evidence-based standard of care. To say that is a lie, or is at best redefining the term evidence-based. What this is a social contagion. It is based in pseudoscience and radical ideologies. And it's sweeping across our country and encouraging children to make irreversible changes to their gender. What's worse, it's coming from adults and institutions who know better, to include our children's hospitals. Institution.
Okay, we're going to pause right there.
Wow.
It's a pretty powerful statement just out of the bat, and we're contrasting what is kind of normal conventional understanding of issues like gender and the experience of adolescence, and this kind of radical new way of conceptualizing gender that has washed over our society with the idea that this is settled science. Everybody agrees on this, all the smart people, all the right people agree on it, and it's really just those backward bigots that hold on to those outdated notions. Is that a way of framing this debate that you've encountered as well?
That is definitely a way that people in my political party and on my side of the political divide are currently framing things. And it's just so wild for me. I call myself politically homeless right now because.
Now, when you say your political party,
yeah,
I
I've been a
assume this means that
Democrat. Yeah, I'm a Democrat. I'm a Democrat. I've been a Democrat since before I could vote. I remember arguing with my dad about Ronald Reagan. I was like, dude, because he said something about trees causing as much air pollution as cars. And I was like, this man has confused carbon monoxide with carbon dioxide. Dad,
no.
He's dumb. Don't vote for him. And he's like, no, he's for the small businessman. So yeah, so I've been arguing on the Democratic side for decades, many decades.
Yeah.
And, you know, yeah, I actually, I said on Twitter that I went and volunteered for Elizabeth Warren on the Democratic primaries. And then we had this like, everybody introduce yourself and share your pronouns. And I was like, seriously. And so I introduced myself. I did not share my pronouns. And like the temperature in the room went down 5 degrees. And I was like, I never
Wait,
went
what
back.
year was that?
That was 2019, I guess.
Wow, and it was already that
It was
polarized.
it was already like that. Well, that's the thing. And then they had that LGBTQ blah blah town hall, and a cute little trans kid, a cute little, kid who had been socially transitioned, took the mic and asked Elizabeth Warren what they were going to do for trans kids. And Elizabeth Warren said that she would vet all of her cabinet level decisions, like for the Secretary of Education, by this little kid. Like, I will let you vet my choice. And I was like, oh my God. So yeah, that was the end of my, And actually Joe Biden seemed more reasonable. Yeah.
That is saying something.
Yeah, Anyway,
I think
my party is not covering themselves in glory right now. They really are trying to push this line that the science is settled and that anybody who says otherwise is just ignorant, they're uninformed, they're bigoted, they're far right, all these kinds of things. I mean, when I submitted a paper to the journal Pediatrics, the Journal for the American Academy of Pediatrics, the title of it was Far from Settled Science. That was my title.
Well, this brings it to the point of something that he mentioned. He said that you can't just say that this is evidence-based care, that affirmative care is evidence-based care. He said you're either lying or you've redefined the term evidence-based care. What is he talking about there?
Evidence-based medicine is a term that I believe was developed by Dr. Gordon Guyot at McMaster University in Canada. And in Toronto, I think. And it is an attempt to remove sort of the vagaries of human psychology from the practice of medicine. So you can't just ask the great man, what is the best thing to do? And he says, well, in my decades of experience, I have found that blah, blah, blah. I mean, that's
Right.
usually how medicine goes. It's like, no, we need to get data and we need to evaluate that data. We need to evaluate those studies for bias. And then we need to do a review of the evidence, but not just any review of the evidence. It needs to be a systematic review of the evidence where you set out your criteria of which papers you're going to look at. And then you have, pre-existing published criteria about what you're looking at and how you're going to look at it. And then you look at the papers and then you run the numbers. That's a systematic review of the evidence. Hasn't been done in the United States other than Florida.
And then we'll learn later in this debate that other countries that have conducted those systematic reviews universally come out saying the evidence is not there to justify the flagrant use of these protocols on children without it being considered an experimental treatment that is under strictly guarded protocols of research. And
Yes.
so they've had to kind of backpedal on just the affirm everybody, hormones for everybody, puberty blockers for everybody sort of paradigm. So I think it's
Right.
important as we go through this debate for us to really understand what is the core issue. And that is going to be looking at the text of the bill that he mentions. Now, it's actually a pretty short amendment. And this is it from Crenshaw's website. It's an amendment that he's calling the Children's Hospital GME Support Reauthorization Act of 2023. There's some stuff in here that is just, little edits, changing years because they're modifying a pre-existing authorization. And then they're adding this one point, which is if at any point during the preceding fiscal year, such hospital furnished gender affirming care as defined in subsection G that we'll get to an individual under 18 years of age, then they will get no payment if they have done any of these things. So then if we go down to section G, we can say that gender affirming care, except as provided in subparagraph B, so there are some exceptions we'll get to. The term gender affirming care means with respect to an individual, any of the following: performing any surgery for the purpose of changing the body of such individual to correspond to a sex that differs from their biological sex, including castration, orchiectomy, scrotoplasty, vasectomy, just a whole bunch of terms that'll be familiar to surgeons and to doctors that are changing the anatomy of somebody for all of these secondary sexual characteristics. And that includes not only genital surgery, but also chest surgeries, as well as facial reconstruction and thyroid surgery. So it may
I
go
think they
beyond
mean like the cartilage here, yeah.
right, exactly,
spots.
to remove the Adam's apple or something like that. Then any plastic surgery that feminizes or masculinizes facial features for the purposes described in the first section. So Dylan Mulvaney famously underwent a facial feminization surgery. He's an adult, and this bill does not cover adults, but having that surgery out there on TikTok becoming more popular will increase the interest that kids may have in it.
Mhm.
And the placement of breast implants, any fat or artificial implants in the gluteal region. Those are just the broad gamut of surgical interventions that have been proposed in any context of gender affirming care for adults or children. It's being very broad in how it defines that specifically for that. Then after surgery, it goes on to dispensing, distributing, or otherwise conveying medications for the same purpose of altering gender or sex characteristics, including the GnRH analogs, cross-sex or wrong-sex hormones, estrogen. And then it goes into the exceptions. And this is important because there's some misunderstanding about the nature of this bill. But it's saying that basically, except in cases where individuals may have both ovarian and testicular tissue, an individual where a physician has determined through genetic or biochemical testing that they don't have normal sex chromosomal structure or steroid hormone production, or an individual experiencing some major medical complication, infection, disease, injury, or disorder caused or exacerbated by prior gender transition procedures, or an individual suffering from a physical disorder, physical injury, or illness certified by a physician that places them in imminent danger of death or impairment. So this may be the first time that you've seen the text of this bill. What strikes you about it, if anything?
Well, I think
I know
it's
that,
pretty thorough. I do
yeah,
feel like he
that's
had
the thing that
staff,
really,
and it looks like he has staff that did some reading
yeah.
and are pretty well informed about what gender affirming care. It doesn't mention testosterone blockers. I didn't see anything about spironolactone, although I'm having a hard time reading that print on
Yeah,
my
it
screen.
is kind of small, actually. I wonder if I can do anything about that.
But anyway, that's the only sort of gender affirming care thing that I didn't see listed there. It would be
Yeah, it does,
insane though to give somebody spironolactone and not give them anything else.
yeah, it does
So,
mention puberty blocking drugs as a general category.
right. Well, spironolactone is used for testosterone blocking, and the thing is, it's got many other uses. Dermatologists use it. Obviously, nephrologists use it because it's a diuretic first and foremost. So, oh, there you go. Now it's bigger.
Yeah.
But yeah, no. So I guess the main thing I notice is like, hey, that's pretty thorough.
Yeah,
Like,
and it
this isn't
sounds
just
like
shooting off the mouth.
whoever put it together was paying attention to the debates that have happened in some of the other state things, because one of the complaints that has come up is that if the state comes in and with a heavy hand just says no surgeries, no hormones, no anything, then it kind of leaves people who are in the middle of an affirmative care paradigm hanging, because some of these therapies, hormonal therapies, are something to go cold turkey doesn't necessarily have the best patient interest in mind.
No,
And
it's not good.
particularly when you listen to some of the detransitioners who have undergone some of the more invasive surgeries, they're left with the dilemma of should they pursue further surgery still to try to correct or reconstruct what they lost before. And it's something that, really clinics have not been prepared for that dilemma, because everything has always been affirmation only. And so the question of what do we do when it goes wrong, or when a patient detransitions, that's kind of just left as an afterthought.
It hasn't been considered. There are no codes. There are no ICD-9 codes. ICD-10. There are no codes. There are no codes for detransition.
Exactly.
Yeah, diagnostics or procedure for detransitioners.
All right, so let's finish his discussion.
That are supposed to be tethered to sound science and their Hippocratic oath of do no harm. Now, maybe I'm an optimist, but I do believe that science and evidence will win out in the end. In the future, we will look back at these gender-affirming therapies as we now look at lobotomies and electroshock therapies. I have some reason to be hopeful. Notably, Great Britain's National Health Service restricted these clinical interventions for minors just last week. Reviews published in the British Journal of Medicine, the Journal of the Endocrine Society, even in the American Academy of Pediatrics, all cite the lack of evidence.
All right. So he made a couple of good points there. Number one, pointing out that Britain, we've all been kind of waiting on pins and needles for what their final decision was going to be. They preliminarily said that there were issues. They preliminarily said they were going to close down the Tavistock, and then we just in the last couple of weeks found out that they were going to in fact cease just the blank check writing of puberty blockers, of cross-sex hormones, unless it was done in a very structured research capacity.
Exactly, which is following what Finland and Sweden have already done.
Yeah, because their protocols, and really any of the protocols that you find, were originally justified and based on the Dutch researchers' protocols, but if you go and look at the papers of the Dutch researchers, there's very specific inclusion and exclusion criteria, and there's a measure of checking into any coexisting or comorbid conditions before a patient would qualify. And none of those precautionary measures have been used to screen patients in these other places. They've just been giving them carte blanche. And so it means that we're applying it to a completely different cohort of patients, and you cannot apply the anticipated outcomes to this broader population.
Also, the outcomes were not nearly as impressive as people will have you.
Exactly. Yeah, that's the other side, because of the way that they did the pre and the post assessment, where they did the switcheroo of the assessment.
Exactly. Switching the scales led to their only really impressive change in scores. Yeah.
Okay, so let's keep going here.
For the record, this review published in the Journal of Endocrine Society that found that there is, quote, low quality evidence for the idea that hormonal treatment improves quality of life, depression, and anxiety among adolescents. Now, here's the important part. This was a systematic review, which by definition is not cherry-picked data, but it's an all-encompassing review of all the data. It has thoroughly debunked the notion that any of these treatments are, quote, evidence-based, let alone recognized as, quote, standard care. My colleagues are using these terms not as accurate representations of the data, but as propaganda. Now, this funding program is reauthorized every 5 years. It provides taxpayer funds to train resident physicians at children's hospitals across the country. It's true. It's been a bipartisan funding mechanism for years. Let's keep in mind something, though. This is taxpayer money. And when 70% of taxpayers oppose these barbaric treatments on minors, then taxpayer money should not fund it. That's why I'm stipulating that as part of this reauthorization, we will not provide any funding through this program to children's hospitals that push gender transition on minors through puberty blockers, hormone therapies, and surgeries. Let's be clear, because there's another lie that's been told. It does not prevent any mental health therapies at all. Despite these lies being told, it does not prevent those kind of therapies at all. This is the issue of our time. This is a hill we're going to die on. It's too important. It's too important to protect our kids from this. In my very limited time, I have too much limited time, so I'll wait for my colleagues to yield to me to ask questions, and I yield back.
All right. So that's Crenshaw's kind of opening statement, framing the debate. I do like that he acknowledges that while he believes he's on the side of compassion and safety and protecting kids, he acknowledges that the people who oppose his bill also believe that they're on the side of safety and compassion. What's your take on that? Is that your experience too?
That is totally my experience. I got interested in this in 2018. And then in the fall of 2019, I went to the American Academy of Pediatrics National Convention that was in New Orleans that year. And I was going to try to talk to other pediatricians about gender medicine, except that as it turns out, I'm really bad at politicking, like one-on-one. But I did go to a presentation, you know, because when you go to the AAP national meeting, there's like 10,000. It's amazing. There are thousands and thousands of pediatricians attending this meeting, and they have giant plenary sessions in big convention halls. And then there's all of these smaller sessions where it's like the latest on diabetes care, the latest on, you know, this or that. And so there was a presentation on gender medicine, on, you know, on gender dysphoria and treatment of same. And they had three sort of gender doctors, one from the Northeast, one from the Southeast, and one from New Orleans. And I don't remember the names. I have it written down somewhere. But they had put it into a double-sized conference room, and it was still packed. And those doctors were so thrilled to see the room filled with people. And they immediately assumed that we were all there because we wanted to learn how to be life-saving heroes like they were. And that's why we were there, because we wanted to know more about this and how can I help these kids, etc. And at the end, you could ask questions. And I stood at the microphone. And when I asked, I don't remember what my question was, but my skepticism was apparent. Yeah. And after the session was over, I got mobbed by all these pediatricians who were like, "Oh, I am so glad you asked that question. I don't know what's going on. This is very confusing to me, you know." And I'm like, yeah, this room was not full of pediatricians who wanted to be life-saving heroes and help these poor children. This room was full of pediatricians who were like, this doesn't really make sense. Like, this doesn't track with what I understand about child development. This doesn't track with what I understand about suicide prevention. You know, all of these things, it just doesn't.
Crenshaw alludes at one point to the idea that this is going to be a sort of medical misadventure along the same lines as lobotomy surgeries in the past, as other medical or surgical interventions that everyone thought was really good and solved the issue. And there was so much bias involved in the people who were promoting these interventions, and it wasn't allowed to be checked by people that didn't have those same biases, whether it was research or publication bias, that would just kind of be a steamroll forward ahead. And it would only after lawsuits started happening, after people started looking at the dissenting voices and the contradictory data, that people said, hold on a second. And so we as a society, we like to trust our doctors, and we have this idea that we're in the age of science and reason. And so any of these authority figures must have done the data, they must have done due diligence, and we can just trust them.
Right.
And I see somebody like you, a busy pediatrician, your focus is not gender and all of the intersections with endocrinology and psychology and all those things. And so you just defer to the experts. And I
Right,
think that
right.
a lot of pediatricians do that. They just don't have time. And then there's the whole liability and political. Who wants to get involved in that? We'll leave it to the gender experts. And that segmentation of practice, I think, has kind of led to the possibility of these ideological bubbles existing in the realm of medicine.
Yes, very much so. I mean, I had a talk with a friend of mine, one of my best friends from residency, and just when I was getting started on this, and I was very worried about it. And she's like, this whole thing is very complicated and I don't understand it. So I just want to refer to the expert because they're the expert. And I'm like, but they only do one thing. Like once you've made the referral, that's it, There's
Well,
no differential diagnosis being performed.
Yeah.
They're not ruling anything out.
So I think you and I kind of share kind of this perspective about putting a great deal of value on the evidence-based medicine, which means you do need to pay attention to the downside of these things and acknowledge the lack of long-term data and let the low quality of the evidence guide whether or not you implement irreversible intensive therapies on patients for which we already have a history of people desisting at very, very high rates. And I think one of the key things that is causing this shift in perspective is the gender ideology concept that that there really are, in a very common way, kids who are trans. And so they start with the definition of this is a trans kid.
Yeah.
And so the dysphoria then is because their transgender identity doesn't match their physical body. And so a cure then is altering the physical body to conform to their trans identity. Now that's an ideological concept of this whole paradigm. And if you start with that position, then the compassionate thing to do, the medically ethical thing to do is these interventions. And you would see any measure to stop these interventions as a form of doing harm. So the whole concept of first do no harm gets flipped on its head because you've assumed that a trans kid exists.
Yeah.
And that's in contrast to the notion of, rather than starting with the identity, start with the symptoms and say this is a child who is experiencing gender dysphoria. And then you don't define the cure by changing the body to match the dysphoria. And that's that clash of perspectives that I think once you unravel that in your head, you can understand how both sides will see themselves as compassionate and working towards, the better healthcare for all of these patients. You just have to decide which of those perspectives actually aligns with reality and with the human experience. And that's kind of the learning process that's involved with really digging into all of these things. So with that being said, there are two giants of political testimony that we get to see kind of square off knuckle to knuckle a little bit here in this hearing. And that the first one is Dr. Meredith McNamara, who is an assistant professor out of Yale, who runs a gender clinic. And she's actually shown up in several of these different hearings, most famously in the Florida Medical Board hearings, where she was subject to some pretty intensive questioning by other physicians. And she's made a few appearances on on various news programs advocating for that gender ideology perspective, where there are trans kids and our interventions needs to go to reconcile trans kids with their trans reality. And then on the other side, we have Dr. Grossman, who is a pediatric psychologist, I believe, or a pediatric psychiatrist. Yeah, who has shown up in some documentaries. I believe she was in the What is a Woman documentary and in various other state hearings advocating for that more traditional perspective of this issue, which is that there are children who are experiencing gender dysphoria and that we already have some good information about the types of interventions that can have a positive effect that don't go to these irreversible hormones, blockers, and surgery that the affirmation models are advocating for. So the hearing actually starts out with allowing McNamara to give about a 5-minute testimony, and then that's followed by Grossman, and there's some really great exchanges that happen there. So let's go ahead and get to the meat of it.
I recognize Dr. McNamara for 5 minutes for your opening statement.
Thank you, Thank you, Health Subcommittee Chair Guthrie, Ranking Member Issue, members of the subcommittee. I'm a board-certified pediatrician and a specialist in adolescent and young adult health. I've spent 12 years in medical training and direct patient care and in clinical research. I'm honored to serve the diverse needs of young adults aged 12 to 25, and as an assistant professor at the Yale School of Medicine, I teach medical residents, students, and fellows. I am also the co-founder of the Integrity Project for Child and Adolescent Health, which seeks to infuse health policy debate with scientific evidence. My testimony today reflects my academic and clinical work, as well as medical consensus, and not the views of my employer. The amendment to the Public Service Act before you proposes to defund pediatrics training programs throughout our country if these institutions provide the standard of care to transgender youth. I'm honored to speak here today on behalf of esteemed colleagues throughout the nation who provide this best practice medical care for children and youth, including trans youth and their families. As a physician with a commitment to patient care, I'm honored to be able to do more for them here than I can do in the office. The past few years mark a rapidly shifting and hostile political climate towards medical care for transgender people with a harsh focus on youth. Care that should be a private matter for families, patients, and providers is now being directed by legislators based on unsupported fears and misinformation. I understand that this care may be confusing to those who are not medical providers with expertise in treating this population, or those who do not have a personal connection to a transgender person. That is why it is critical that this body base its decisions on facts and accurate information. Most of us here would not disagree with that. From my position as a medical practitioner and a member of a large community of experts in this care, I see 5 categories of misinformation. Denial of the medical condition of gender dysphoria, false claims about standard practice, false claims about the evidence that backs care, false claims about the safety of treatments, and an attack on medical authority. And I'm here to ensure that you have the facts to address this misinformation. Gender dysphoria, the long-standing and significant distress that many transgender people have from the incongruence between their gender identity and the sex they have at birth, is real. It's a recognized and serious medical condition. Transgender people of all ages exist. Their healthcare is based on established standards of care and clinical practice guidelines, which are themselves based on substantial medical research and evidence, as well as decades of clinical practice. Based on these standards, youth and parents receive informed counseling about the risks and the benefits of specific treatments, and every major medical organization has endorsed this care.
So I want to make sure that we get a chance to comment on some of what she said already. She lays out her credentials.
Yeah,
and
I want to note that she said 12 years of medical training, and I'm guessing that's 4 years of medical school, 3 years of pediatric residency, 3 years of an adolescent fellowship, which means she's 2 years out of her fellowship.
There's a great line later where Dr. Grossman says, you know, no offense, but some of these people like Dr. Zucker and some of the other people that are critical voices on this have been doing this since before she was born.
Yeah.
And that's really true. But the thing is, it is the younger generation who, even before medical school, were infused with the critical theory ideologies that underlie all of this.
It's true.
And so whether it's just aspects of gender studies informed by queer theory, informed by a lot of the new philosophies that are in vogue now that have kind of transformed how we think of issues like racism, like sexism, like gender, and on a broad spectrum, all of those inputs have gone into these younger physicians as they went through undergraduate and found root as they reconceptualized what ethics meant and, you know, what it meant to care for all people as physicians.
Yes.
And
yes.
I don't know if you've
think,
seen. Go ahead.
I was going to say I think that's what happened to the American Academy of Pediatrics. Jason Rafferty is the person who wrote that 2018 statement. There's a really unusual little caveat that says that this entire document was written by Dr. Rafferty, and he's responsible for it. And it's got so many errors, but we won't get into that. Anyway, he was just barely out of his training. I mean, he was probably in his training when he started working on that. So I really get the impression that all over, sort of young doctors run up to the older, the people my age, the people in their 50s, who are sort of running things. And they're like, oh my God, trans rights. It's the new civil rights thing. Trans is the new gay, and we need to be on the right side of history. And the older doctors are like, oh, well, yeah, I want to be on the right side of history. What is this new thing you tell? And then they say blah, 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 blah. And they're like, oh, wow, that doesn't make sense to me. But okay, how about you write something up and we'll take a look. And I think that's what happened. And then it was like nobody checked it.
Yeah.
Nobody.
There were some committees. There were some committees that reviewed it, but the committees were also populated by young clinicians with an activist mindset. And then the best part about it, though, is that it was then published in the official journal of the American Academy of Pediatrics with no public comment, no public review, no dissenting voices given. And now this is the official position of an organization of over 60,000 pediatricians. And now everyone can say, oh, it has the backing of the American Academy of Pediatricians and tens of thousands of doctors, when that's not actually, it has the backing of the small handful of people who bring an ideological perspective to this practice that not everyone agrees with.
Right. You mentioned the What is a Woman documentary. Remember the chicken lady? The Michelle Forcier, the blue-haired chicken lady who said, can a chicken cry? Can a chicken commit suicide? She's the mentor of Jason Rafferty. He trained under her.
You're kidding.
I'm not kidding. She is the source.
You can trace these
things. Crazy. Yeah, you can trace it.
Yeah.
And just let her talk and she'll convince you of something.
Yeah. So Dr. McNamara talks about 5 categories of misinformation. She starts out with denial of the medical condition. I was surprised she started out with that, because as heated as this debate gets, I've not really seen either side say there's no such thing as kids who have gender dysphoria. I think that's a description of an experience that's real. And the question is
not a thing.
And I was going to say, the question is like, do you think that experience of dysphoria is a problem of the mind or a problem of the body? And which side should you address? And the perspective of the gender ideologues is that it is a problem of the body not fitting the identity. And so we've got to change the body through hormones or surgery. Whereas the people in the more traditional concept of gender in medicine say, well, that is an experience in the mind that, by the way, is not terribly uncommon. We've just found new ways to frame it as a narrative that has a direction of how you go. People, especially teenagers, not feeling comfortable with the experience of adolescence, with prescribed gender roles, like all of those things are a part of the human experience, that maturity and reconciliation with society and your changing body are a part of the adolescent process. But now we've given them a whole new menu and a whole new direction to go, and you're stunning and brave when you do it, and nobody can criticize you, and you can demonize anyone who doesn't agree with you, which are all things that feed into the adolescent mind.
Right. And you can be a whole new person. You can leave all those mistakes of your past behind, and no one's allowed to talk about it because you have a new name and you're a new person. I mean, that is so seductive. Who wouldn't go for that? But something that struck me was she said that gender dysphoria is real and that trans kids exist, or that trans people exist at all ages. And I'm like, how young does this go?
Well, and we've seen, there's a TED talk where one mother claims that her child in the womb was even expressing a trans expression, which
I haven't seen that one.
That's a little bit of a red flag, that there may be something more in the mind of some parents that are advocating for this than what are coming from the kids. But I think that's where Munchausen by proxy is something that gets brought up as a potential dimension of some patients that may be presenting, particularly in the social media age, where there may be a degree of clout that go along with having a kid who is unique and special in these ways.
All right. My lights just turned out because I'm not moving enough at work. Hopefully you can
Okay,
still
after
see me.
denial of medical, she says false claims about standard practice and false claims about evidence. And that, that point on this about what is the data, what is the evidence, I think is a hill that people seem to be fighting on, and everybody has their own separate hill. Like the people in the side of this doctor believe they have the evidence and they have the standards of care that are justified by the evidence. Whereas everybody else is like, well, let's look at that evidence. It's weak, even by the rating of the people who have promoted it. The Endocrine Society rated their evidence as low quality or very low quality on almost every dimension dealing with pediatric gender affirmative care.
And yet they gave strong recommendations for various things. Strong recommendations based on low quality evidence.
Right. And
it's unprecedented.
Even Gordon Gaillard, who's the godfather of evidence-based care, says, you can call it consensus medicine, where you get a bunch of experts and everybody in that older paradigm, the people who are heavily invested in doing it say this is what should be done because this is our experience. But the whole point of going back to a evidence-based perspective is to remove the biases that are inherent with that and really take a good look at the evidence. And frequently you'll discover that things that you thought had strong evidence were not, and then you should temper the nature of your recommendations based on that quality of evidence. So that's going to be something we'll see a little bit more. And then false claims about the safety of treatments and an attack on medical authority. What do you think she's talking about, the attack on medical authority?
Well, if you're saying that, what the AAP said is wrong, then I guess you're attacking the authority of the American Academy of Pediatrics.
Yeah.
So she's and it's interesting because she's like, every medical organization in the United States just gets left out. It's, it's really interesting because, once again, I'm a lifelong Democrat, but the USA isn't typically thought of as a left-wing rah-rah cheer. But we're doing our own thing now.
But that allows her to make that strong statement. Every medical institution in the United States. And it sounds
She doesn't
powerful.
say in the United States, though. She just says every medical institution. She implies in the world. But it's just because her world is confined to the United States, maybe Canada.
All right, well, let's keep going. Let's see here if we bring her back up and press play.
As a pediatrician, I must also address the proposed amendment. Pediatrics residencies and fellowships are the backbone of healthcare for children in this country. During the triple-demic of influenza, COVID-19, and respiratory syncytial virus, also called RSV, it was pediatrics residents and fellows who worked every hour of every day to help children survive life-threatening respiratory diseases. They help NICU babies get to kindergarten. They keep outpatient clinics flowing so the kids get routine well care. Residents and fellows form a pipeline of research and innovation that makes this country a global leader in every area of pediatric medical science. This bill would require children's hospitals to deny kids health care to maintain funding.
That's interesting that she juxtaposes all of these non-gender affirming interventions and activities and then says that it's going to require hospitals to deny kids health care to maintain funding, as though those were the things that the bill is trying to say that they shouldn't do.
It's all healthcare. It's just all the same. It's saving babies and saving trans kids. It's all the same. Life-saving care, baby.
Yeah. Well, it seems like a rhetorical maneuver that's not really rooted in, let's look at, what's actually going on here. And she continues.
As a practical matter, there is no way to banish all transgender youth from children's hospitals, nor is there a way for pediatricians to simply refuse to provide these youth with medically necessary care. All kids suffer when their legislators remove parents' rights and prevent pediatricians from providing this standard of care.
Okay, so this implies then that the hormones and the surgeries, and later they're going to argue it's not really the surgeries, it's the hormones, because no surgeries are being done on kids in these hospitals. But we'll look at the data behind that. But basically that those puberty blockers and cross-sex hormones are essential life-saving care.
Standard
And
of
so the
care,
stakes
she
are high.
says.
And yeah, standard
Yeah.
of care. And the stakes are high and they're essential. Now, is that the case? What did we do before whoever it was discovered the cross-sex hormones or the puberty blockers? Because there was, these are
Mhm.
new.
Puberty's been going on for a while.
Yeah. These are new medical technologies in the last several decades, and people existed before then. And
Mhm.
it's not like we created a new breed of human just by discovering a new intervention.
No, no.
But now we see it as that.
And it's not like diabetes, where kids with diabetes were, starved to try to keep them alive,
Right.
but they still died very young before we figured out how to inject them with insulin. That is
Right.
not. We don't have stats like that.
Yeah. And so, I mean, if what they're saying is true, and that is that kids experiencing gender dysphoria who don't receive any surgical or hormonal intervention will kill themselves, well, then that should mean that when we start implementing these therapies, we see a dramatic drop in the degree of suicide rate. And that in those states where, or in those countries where they, stop offering these things, the suicide rate should go up. There should be like a hidden epidemic of these suicides. And in
Mhm.
fact, when people look at the data, it doesn't reflect that.
No, we're not seeing that. Not seeing that in Finland. Not
Yeah.
seeing that in Sweden.
But the thing that doesn't get mentioned in all this, in Sweden, where they have done that 30-year review of
Mm.
people who got these interventions as adolescents and young adults, 30
Mostly
years
as
later.
adults.
Yeah. Okay. So
Yeah.
as young adults,
They were all
30
adults. They were all adult transitioners, but it was a high quality study in that Sweden has a single nationalized health system, and so they
Right.
have very good records. They didn't have a lot of loss to follow up, and so they were able to follow these people, and yeah, they didn't do well. They had a higher mortality for all causes,
Yeah.
and
The data on that
19
is like
times higher
19 times.
mortality for suicide.
And that's
It
both
was
genders. If you looked only at, trans men,
It's 40
natal
times.
females, it was like 40 times.
Yeah, 40 times higher for the natal females.
All right,
Testosterone.
hell of a drug.
Exactly.
And I have to tell you, American pediatricians will not accept being told that they have to leave even a single child behind. There's no room for there's no room in our clinics for the government. I had a conversation
She
with
botched the signature line there, but
Oops.
she does bring up a question that I think is worthy of debate, and that is,
Mhm.
we have had traditionally kind of a line between the practice of medicine and government, and there are certainly some intersection, and there's some whether it is through licensing bodies and the state's involvement in that, as well as what happens when medical malpractice happens and what constitutes medical malpractice. So there's some intersections between government and legal realm and medical realm. Is this the right way for the government to try to force a change, and why should the government force a change through this way rather than just letting the medical professional societies and the academics stay true to their ethic of first do no harm and all of the other medical ethical principles?
Well, I think you just said it right there. I mean, if we could get the medical societies to take a look at the evidence, we wouldn't need the government to step in. But it was back in 2020 that I submitted a paper to the journal Pediatrics in which I made a statement that a child less than 8 will believe the adults in their life if they are told that their desire for things that the other sex prefers means that there's something wrong with them. They have a girl brain in a boy body, for example, but it's okay. We'll change your name and pronouns now, and then when you're older, the doctors will change your sex. I said we can't, and it's cruel to imply that we can. And this got sent out to gender doctors for review. And one of the reviewers said that my statement would be upsetting to pediatric readers of the journal Pediatrics. And then another one said that, we really do make a lot of significant changes. So, we do kind of change their sex, don't we? And yeah, it was just amazing.
Yeah.
They would not tolerate having that kind of a statement published, that we cannot change anyone's sex.
And
That's
that
why
just
it's an
points
adult
to,
decision.
yeah,
Yeah.
it points to how, as much as we want to stay true to this idea of evidence-based medicine, you really have to look at the underlying philosophy about the nature of reality, how we define terms, and the way we conceptualize the human experience and human biology, because it's the
Mhm.
redefinition of some of those things that seems to make a form of sense to people adopting that perspective, but it just is so at odds with medical
Right.
ethics in the traditional form, in the traditional sense. So let's keep going.
Trans teen recently. Gender dysphoria began early in puberty and worsened as puberty progressed. Parents sought and received help. This family asked me to tell members of this committee that gender affirming care gave their kid confidence. This teen stands tall, debates international law and model UN sessions, recently in this city, our capital, to compete in nationals. This care was life-saving, life-affirming. College options are limited to states that protect trans healthcare, but even still, this teen is excited for the future that lies ahead. That's what every kid in this country deserves. Please don't make it harder for us pediatricians to get them there.
Thank you.
So she ends with the anecdote about a success story with a trans teen. And I think it reminds me of the criticisms that we've heard some of the researchers point about anytime a positive result of a study is touted. Look, we performed either a hormonal or surgical intervention and the results were good. The patients reported good experience, a positive experience. And then you say, okay, well, how long was the follow-up? Oh, the follow-up was 18 months. And they're like, okay,
Yeah.
in the broad span of life, especially when you're talking about kids, so much changes.
Yeah.
And you don't even know about the things that we're only now discovering, such as children that receive those therapies are anorgasmic. They have sexual dysfunction for life.
Yeah.
And
Or at
all
least
of
the
the side
boys are.
effects.
Yeah.
Yeah. Um, so I don't know. What do you think about the anecdotal story being
Well, I
included in
mean,
the
it's a good political move, right? I mean,
Yeah.
whoa, now the lights are back on. So one of the most powerful tools that a person and one of the most powerful things in the fight for evidence-based gender care is to share the stories of detransitioners.
Yeah.
And it's just human nature. We are storytelling monkeys and we react to narrative,
Yeah.
right? I mean, if you're trying to change someone's mind, there are some people in the world whose mind can be changed with facts and figures, but they are a small minority of humans. Most humans change their minds based on emotion, and anecdotes move people emotionally. People outsource their opinions. They very much, like the interesting study that showed that among people who were skeptical of climate change, the more education they had, the more resistant they were to changing their mind.
Mhm.
Because you make your conclusion and then you array all of the facts onto the framework that you already have. So I'm not surprised that she's closing with an anecdote. That's what you do if you're testifying to Congress.
She gave them a human face that they can
Yeah.
now visualize as they talk about this. And all right, I think we should move on to Dr. Grossman's testimony next. All right, let's keep going.
Thank you for your testimony. The chair now recognizes Dr. Grossman for 5 minutes for your opening statement.
Thank you, Chairman Guthrie. Chairman Guthrie and members of the subcommittee, thank you for the opportunity to address you. My name is Miriam Grossman. I am a board-certified child, adolescent, and adult psychiatrist, author, and senior fellow at Do No Harm. I have been taking care of patients for 45 years. I'm going to use my time to respond to Dr. McNamara. First, I'm struck by her use of the phrase, sex assigned at birth. Sex is not assigned at birth. Sex is established at conception and it's recognized at birth, if not earlier. Dr. McNamara claims that her views are science-based, but to claim that sex is assigned at birth is without any scientific basis whatsoever. Its language misleads people, especially children, into thinking that male and female are arbitrary designations and can change. That is simply not true. Dr. McNamara claims that social and medical interventions are the only evidence-based treatment and that scientific evidence shows it is life-saving. Without it, she's warning us, kids will commit suicide. Well, a growing number of countries have effectively banned the care to which she's referring. And thank God there's been no wave of suicides or other mental health catastrophes. 3 years ago, Finland placed strict limitations on medical interventions for minors. Sweden did the same thing after a 14-year-old girl was found to have osteoporosis and spinal fractures from puberty blockers. An investigation concluded, quote, the risks of anti-puberty and hormone treatment for those under 18 currently outweigh the possible benefits. The UK conducted a review and called the evidence very low. They've also placed severe restrictions on the care that Dr. McNamara calls life-saving. Norway also analyzed the data and has made similar changes in policy. The National Academy of Medicine in France warned, quote, great medical caution must be taken in children and adolescents, given the vulnerability of this population and the many undesirable, even serious complications the therapies cause. Doctors in New Zealand and Australia have published similar statements.
All right. She's citing the broad menu of European countries that have put the brakes on or reversed courses in these therapies. And the unspoken thing underneath that is that they've been doing it longer than we have in America. Our
Right.
clinics here in America were because some clinicians went and learned what they were doing and brought it over here and started opening up clinics here. And so they have, 7 to 10 years ahead of us in doing these interventions. And so there's a little bit of hubris in the idea that, well, they may be reversing course, but we know what's right. We're doing it better, when they're the ones who have the longer data, who see the outcomes better.
Yeah, no, you're right. You're right. And she's been taking care of patients for 45 years.
Yeah.
Which I do think is longer than Meredith has been alive. Yeah.
And they sat them both next to each other, and it is pretty interesting to watch the facial expressions of the opposite person when they're talking, for sure.
Yes. Yes.
All right, let's keep going.
Is Dr. McNamara suggesting that all these countries are rejecting evidence-based treatment and placing their kids at risk of suicide? Regarding that point of view, Finland's gender expert, Dr. Rita Kaltiela, said, quote, it's purposeful disinformation, the spreading of which is irresponsible. All 7 countries, and Florida too, of course, concluded that kids don't need their development interrupted, the girls don't need their periods stopped and their voices lowered, and the boys don't need to grow breasts. What they need is psychotherapy.
All right, so she's got kind of a little powerful mic drop moment there. And people might say, well, she's a psychiatrist. Of course, she's going to assume psychotherapy because she's not familiar with all the great hormonal and surgical interventions and the positive effects of that. What would you say to that type of criticism of her perspective?
Well, I mean, you could point out that the recently published Chen et al. Study in the New England Journal of Medicine, published in 2023, which was an NIH-funded study over multiple of the best gender clinics in the country, had a completed suicide rate of 2 suicides in 315 patients. That is an astronomical rate of suicide. It's 50 times the background suicide rate for.
And
these are patients. These are patients getting the treatment. These aren't patients waiting for the treatment. These are patients getting the treatment. So Dr. Michael Biggs is a sociologist in the United Kingdom, and he did a FOIA request from the Tavistock, and he got information on completed suicides of Tavistock referred patients. And so he had a data set of about 15,000 patients. There were 4 suicides. 2 were in patients who were being treated, and 2 were in patients who were still on the waiting list. That's one of the big criticisms of the Tavistock, is they got overwhelmed with patients and kids would be on the waiting list for years. So there were 2 on the waiting list, 2 not getting treatment, 2 getting treatment. There's like no big difference there. And yet that's 4 out of 15,000 in the United States. In the published study with the top-notch, state-of-the-art gender care, 2 out of 315 patients committed
And it kind of,
suicide.
it reminds me of, we mentioned Polly Carmichael's 2016 PATH lecture. It had 2 bombshells. And the first one was what we mentioned before, which is that of all the kids that started puberty blockers, like 99% of them went on to further cross-sex hormones and surgery. The other one was that when they looked at the outcomes of the people who had been through the protocol, there wasn't improvement in depression, anxiety, all those different measures. It was the same. And so her conclusion was that, they were happier with the changes, but they still had the depression, the anxiety. And so the outcomes were not as glamorous as they had been sold.
That's the thing
so
that,
Go ahead.
Rhetorical, right? The Finnish child psychiatrist was put in charge of the Finnish pediatric gender clinic. And she published a similar thing. She's like, well, if you have a kid who is psychologically stable and doing well, and you transition them, then they do fine. But if you have a kid who's not doing well and you transition them, it does not help.
And if you look at the Dutch protocol, it was not only that the kids didn't have any of those underlying conditions, they also were in a home that was supportive. And so there's a broader social dimension that those clinicians were taking into account that doesn't even appear on the radar in the way that these protocols have been implemented in other places. All right, so let's keep going with Dr. Grossman.
I have other objections to Dr. McNamara's testimony. She insists that her position, only hers, represents standard medical care. What she doesn't want you to know is that there is no standard. There's a debate. There's a fierce debate. And on the side opposite her stand such prominent figures as Stephen Levine, Kenneth Zucker, Paul McHugh, and James Cantor, among others. These doctors are giants in the field. They have been treating transgender patients and gathering data and publishing papers about them, and I mean no disrespect here, but since before Dr. McNamara was born. The point is that those veteran clinicians and others who have wisdom and experience are ignored because they disagree with the current narrative. They're against medical interventions for the same reason those 7 countries are. There is no evidence of long-term benefit, but there is evidence of harm. I'll end by quoting Jamie Reed, the courageous whistleblower from the Children's Gender Clinic in St. Louis. I believe that hospital receives the medical education funding that we're discussing today. She said that doctors at that clinic said, "We are building the plane while we are flying it." We are building the plane while we are flying it. That's how they described the treatment at their gender clinic. Our precious tax dollars should not support such a perilous experiment. Thank you.
Oh, so that was, she is a forceful voice for sure. What do you think is meant? What should we learn from that statement, and why is it so significant that this clinic that was treating kids with these affirmative care models is building the plane while they're flying it?
Right. Well, I mean, it's not a new phrase. It indicates, this is super complicated, and we're kind of making it up as we go along. Is what I get. I mean, that conference that I mentioned, or the presentation at the 2019 AAP, they, in so many words, when they were thinking that we were all there to learn how to do gender medicine, they're like, you can do this too. None of us know what we're doing. We're all just making it up as we go along. Like, if I can do it, you can do it. It was very much the attitude.
It's so
And
weird because in my training and in doing rotations, because I'm a physician as well. I'm a radiologist. I went through Boston Children's Hospital for my radiology pediatric course, and there's this idea that these are the most vulnerable patients, the most critical patients, where if you mess up, they have a whole life ahead of them. So the legal liability, everything, the stakes are higher in kids. And what that
Yeah.
means is that if you have an intervention that has as irreversible, as dramatic an impact in an individual's lives as these hormones and surgeries do, you better make damn well sure that the evidence is there, that it's going to do them good, and that that's going to outweigh the harm. And
right.
for something that would be described as building the plane while you're flying it, no, it would be we're looking at the schematics, we're testing things, we're using simulations before we actually apply it to patients, because it's not the tax dollars, it's not the plane, it's the lives of the individual kids who are being affected by these things. And yeah, patients will demand therapies, what they want, and a clinician that just said, well, they're demanding it, I have to give it to them, is taking themselves out of the competent professional role that they should be playing.
Right. Might as well just hand out the prescription pad.
Yeah.
Yeah.
All right. Well, okay, we're fired up. Let's see. Okay, so now
She's done, I think. Yeah.
just now the whole of this thing is about an hour and 15 minutes, because I took out, they debate a bunch of other stuff too. It's the trans stuff is only a little bit. There's also dental and neonatal care and other things. So I've only taken the pediatric stuff out. And for the first part of it, we get a lot of questions for Dr. McNamara and allow her to basically untangle Dr. Grossman's testimony and show why she's just very, frankly evil, because she's giving misinformation that's going to cause people harm. So let's see where that line of questioning goes.
Okay. To Dr. McNamara, you just sat through testimony that I believe is chock full of dangerous misinformation and pseudo-scientific, quote, facts warped to fit, I think, a really outdated narrative.
I just want to say, as we get into this, you've got two physicians on the expert witnesses there. And then we're going to be able to see each of these congressional representatives that are on this subcommittee give their 2 cents about what's actually going on. And it is drawn right down the line of Democrat, Republican, for or against. And this is something that we see a lot, where there's going to be a lot of people like yourself who maybe traditionally were moderate Democrats, but the new direction that everything is going on, you can't just vote along party lines and think along party lines anymore. If you're
stop. I didn't want to think about it. I didn't want to think about it. It's too painful. But actually, you just reminded me, apparently Marin County, right? So the county that's right over you leave San Francisco, you go north on the Golden Gate Bridge, you're in Marin County, one of the most expensive counties in the world, but full of very liberal people, very wealthy and liberal people, and famously reticent about vaccinating their kids, right? They're all very hippie, granola, like, oh. Well, apparently once vaccination became a tribal marker for being a liberal, for being a Democrat, that has totally switched. Marin has a really good vaccination rate. They have one of the highest COVID vaccination rates in the country. And
that's such a good point, because that really is what you can see this has transformed to. It's a tribal marker of which political affiliation you're with.
Yeah.
And it's just, I mean,
and so I confound people. I keep confounding people, because I'm like, no, really, I'm liberal. And they're like, no, you're some kind of right-wing crazy person. Yeah. I'm like,
we heard it's only the Trumpsters, them MAGA people.
Exactly. Americans.
No. All right. So yeah, you're going to hear some emotional, inflammatory language here.
Of the trans experience in our healthcare system. We could spend a long time talking about that, but I want to give you the opportunity for a minute to respond. I've spoken to pediatric endocrinologists in my district who treat hormone disorders in children every day. And as we all go about doing whatever we're doing, this is taking place. This is taking place in our country. And it includes, which I was not aware of, early cases of early puberty in children as young as 2 years old. I'd never heard of that. This causes obviously a lot of serious issues. One of the treatments is providing GnRH, analog therapy, a banned medical intervention under the legislation that's being considered here today. And I again, to have, 2-year-olds, 6-year-olds, youngsters subjected to this is, well, I think you can hear it in my voice. I'm deeply unsettled about this. Do you want to, 30-second response since
Thank
I
you,
ate up
Representative.
some?
Okay, before we get to Meredith's response, because Meredith's going, or Dr. McNamara is going to respond primarily to Dr. Grossman, but this concept of precocious puberty,
Right.
it's brought up a lot. Why is
Yeah.
it brought up here?
Well, it's brought up because that is the only situation, say 10 years ago, where 10 years ago it was happening in Holland, but the only situation where pediatricians were administering gonadotropin releasing hormone agonists to pediatric patients. Actually, now, that she says that, I am curious. I almost want to go back to the text of the amendment to make sure they had a carve out for precocious puberty, because I think they did.
Well, no, they specifically, in defining it, they say it only applies for these interventions being done for the purpose of changing sex characteristics to
Well,
something
there you
else.
go. Yeah. So it wouldn't apply, because when
Right.
basically precocious puberty can happen, at the age of 2, I suppose. I've had patients with thelarchy. So thelarchy is when they develop pubic hair, but then what happens, I've seen that a couple of times, but true precocious puberty is vanishingly rare. It's the frequency of the disorders of sexual development. It's a thing that happens, but it's very rare. It's like how many times you flip a nickel and it lands on its edge and it stands there. It's a rare occurrence. And up until a year ago, maybe 2 years ago, Up to Date, which is a popular online textbook of medicine,
Yep,
the
used it myself.
chapter, what?
I use
Look
it
at all.
myself.
Yeah, I use it. I use it every day. It had a chapter on precocious puberty and the treatment with gonadotropin releasing agonists. And they said that they had a specific recommendation. We only recommended this for kids who are 5 or 6.
Yeah.
Because if they're 7, you're pushing the Lupron implant is there for 2 years. And so if they're 7, when you take that out, they're 9, you might as well, because the normal range for menarche, it's usually girls for some reason that we do this. It doesn't seem to happen as much with boys. That normal range for first period, which is menarche, is 9 to 17. So if you have someone who's moving into puberty early, like age 7, and it looks like they're going to start their periods when they're 8, the opinion of these experts was it's not worth the risks of the Lupron implant to, when the normal is 9 to 17, it's not worth doing the risks if she starts her periods at 8 versus 9.
Yeah. And the
But
irony
if she's going to start
is,
her periods at 6, then you do it.
the irony is that the experience with precocious puberty is brought up as see, look, it's safe. We have all this experience in doing it in precocious puberty. When you look at the protocols for precocious puberty, they're giving it to kids who are starting puberty too early. They're only giving it for, I think, max 2 years, as you're mentioning. There's very restricted, and they're stopping it when the child is in the range where they could go through normal puberty and have all of the symphony of changes that happen in their body that are more than just the sex hormone, that involve brain development, that involve bone development, that involve all these different complex interactions.
Yeah.
And that's totally different from what is happening where they're starting these puberty blockers when kids would normally start to go through puberty, and they're extending it through a significant portion of puberty and beyond till some subsequent intervention happens. And so they're interfering with what would be the normal pubertal process of evolving a child into an adult and all of those changes. And so it's just it's one of those things that when you understand that background and then you hear it being invoked in these debates, it's very frustrating because
there's a lot of very frustrating things in this debate. But yeah. And the reason that they talk about limiting to 2 years is because there were pediatric endocrinologists who were delaying puberty for more than 2 years. And then there were women who had significant adverse side effects, their teeth cracking, their bones breaking from being on Lupron for too long.
Yeah, and they'll tell
It's
you
not
that's
a benign medicine. The data is there. There are already people who suffered adverse consequences for Lupron when it was used to delay puberty, like trying to delay puberty until they're 12, for example.
right, even before the gender stuff. So let's keep going.
Yes. So all 5 themes of the misinformation that I've identified in my work are on display. I'm a co-author of extensive rebuttals with science to all of them. It's entered into my testimony, and those documents have been used to successfully challenge bans on care for trans youth in Texas, Florida, and Alabama. The other testimony espouses 2 levels of harm: abolishing evidence-based care and creating a vacuum. The forced withdrawal of care is akin to experimentation. Dangerous, discredited conversion practices that attempt to convince a young person that they are not gay or not trans. We've moved on from that. Most states have banned that care in this country.
Okay. She just made 2 points that are starting to be seen more and more frequently, if they haven't already been a basic mainstay of this. And the first one is one that the forced withdrawal of care is akin to experimentation. So what she's saying is that if we don't do these interventions, which an honest look at them is that they are experimental, meaning that we don't know what the long-term benefits and the long-term risks are. We don't know the different side effects. I mean, they don't even know basic things about how it affects sexual function because they haven't looked at it.
Right.
So the intervention is experimentation, but they're flipping the switch, flipping the script, and saying, no, preventing us from intervening. That's the experiment. That's the experiment. And so they
with the idea that puberty, that going through the wrong puberty, the puberty that your body is trying to do, that's the unethical treatment, to force the child to go through their own puberty.
Yeah. And that should be a wake-up call or a big red flag. Hey, there's something ideological going on here. There's a set of ideas that are a dogma that cannot be questioned, that are asserted. This idea that people have a gender identity which is completely disconnected from their body, and from which they will have this serious distress to the point of suicide unless we make these changes in their body. And all of that is rooted in this dogma, this ideology, and it allows you to then flip the switch on what is actually going on here. And you just have to say those are philosophical assertions that belong in books by Judith Butler about queer theory and different thought experiments, but to have it just be assumed is the reality upon which we base our medical practice is a step too far. But here it is. The second thing that she did was saying that attempting to convince a young person that they are not gay or not trans. So she's lumped in now conversion therapy with,
that's how you get the liberals. That's how you get the liberals. Is you it's just a thought. Trans is the new gay.
Yeah.
And so there are people in their 50s and 60s all over the country who are feeling kind of bad about their former homophobia and the way they acted in the 80s and 90s. And so they want to be on the right side of history this time, because there were all these people who said, if we allow gays to be married, then the world's gonna like fall apart. Like all these institutions will crumble and our civilization will crumble. And then it came in the weirdest, like sideways, the Supreme Court of Iowa. What? You know, like the first state that allowed gay marriage was Iowa, and Iowa did not fall. And then other states, and the whole thing happened. And then, you know, there were people just feeling like, wow, I guess I got that wrong. And so you just come up to them and you say, well, there's this new civil rights struggle, and it's trans, and these kids are trans, and they just are trans, and it's deep inside them, and trans is the new gay, and we need to be on the right side of history. And you'll get a bunch of people to just line up for that.
They want to be able to have, you know, to be on the right side, as you mentioned.
Yeah, they want to feel good.
If you were confronted with somebody who had that position, how could you make the case that no, these things are in fact different, and it's possible to still be on the right side of history, and draw a line that separates the issue of the gay kid from the trans kid, where engaging in psychotherapy and talk therapy is actually an ethical and healthy thing for these kids? How do you make that case?
Well, I think if you can get them to listen to the fact that many gay people will tell you, and I have been told, that when they were young and they didn't know they were gay, they just knew they were different. They just knew that, like, they saw the world differently, that things were different for them, that a lot of times they conceptualized that as, like, you know, a boy who was drawn to the sparkles, drawn to the flowing fabrics, drawn to like quiet activities with girls and wants to hang out with the girls, then they say, that's not for you, that's for girls. It's a very normal 3 or 4-year-old response to say, well, then I'm a girl. You know, if you tell a 3-year-old you can't have the thing you want because that's for girls, then it's a completely within 3-year-old logic to respond, well, then I'm a girl. Like, if that's for girls and I like it, then I'm a girl. And that happened, you know, all the time. There are like entire social categories, you know, the Fa'afafine in Fiji are those boys that, you know, were drawn to the feminine. And so they're like, oh, you're Fa'afafine. And then, you know, that's your role at that point. They don't get medicalized. So if you can get people to understand that this can just be part of the development of a normal homosexual, and that what they need, the thing that pulls them out of this idea that they're a girl in a boy's body, is puberty. Suddenly, their gonads are pumping out testosterone, and they discover what they're attracted to. Like, it becomes impossible to ignore. If you are a male in puberty, it becomes very clear what you're attracted to. There's a huge difference between the sexes here. But that was, you know, puberty cured gender dysphoria in a supermajority of cases in the before times, in the times when Dr. Zucker, Dr. Cantor, Dr. Levine were doing gender medicine.
Yeah, and I've heard Dr. Levine bring this up in the difference between you know, the gender dysphoria experience and the you know, budding homosexual experience, is that if you look at the population of young patients experiencing gender dysphoria, it resolves through the process of puberty. They reconcile with their biology, and it becomes a part of what is, in many cases, the story of a gender non-conforming child who is going to be gay.
Yeah.
And it's not 100%, but you know, that's
No,
just
not
the broad
100%.
variety of way that people develop. But we've gotten to the point where we've inverted our concept of gender stereotypes, so that rather than gender stereotypes expanding what a boy can be or what a girl can be, they now define what a boy can be or what. So if you are attracted to,
it just feels really regressive to me. You know, it's like, oh, like if you want to paint your nails, then you can't be a boy. You know, or if you want to climb trees, then you can't be a girl. And it's just a lot of what you can't be, you know. And so, like, if you don't fit into this box, then you either need to hop into this box or one of these other new boxes that we made. But we can't just break the boxes, you know. I was a young person in the 80s, and it was all about breaking the gender norms and androgyny. And we had all of these pop stars. Boy George was, wearing makeup, and Annie Lennox was wearing a suit. And, it was just, and Katie Lang was getting shaved by Chris Crawford in a famous magazine cover. And none of these people were medicalizing. They were just having a good time. They were just changing their presentation. But nobody felt the need to do any medical changes.
Things that will sterilize patients for life, make them dependent on drugs for the rest of their life, or have, constant dilation for the rest of their life, and all these other medical consequences. The irony, though, is that if you were to sit down and try to explain to a family, including a kid experiencing these things, about what we've been discussing, that would, under this new way of thinking, be called conversion therapy, lumped in with the same thing as the electroshock therapy and all the other horrific things that were done to homosexuals in, past medical misadventures. And you're evil for doing that, when we have this evidence and this body of data that shows that that has produced more effective outcomes in terms of people resolving their dysphoria and going on to live healthy, productive lives that don't have all of these side effects.
Right. But yeah, somehow the fact that the path of medicalization is a difficult path, it's a beautiful path. It's the only reasonable path. Seems to be the point of Dr. McNamara.
It is toxic for an adult to tell an adolescent that there's something wrong with them. I'm sure there are many parents in the room, and you'd never want your kid to go through that.
Okay, as a parent, it is necessary for you to correct your children and to guide them and to help them navigate the difficulties of life. And that is going to involve uncomfortable truths. And it's going to involve also sharing with them that some of the discomfort, some of the difficulties that they're experiencing are part of the normal human experience, and that things do get better and they resolve, and there are different ways, like that model of that, this idea that you can never contradict your kid or never tell them that there's anything about the way that they conceptualize themselves or the world that could be expanded to consider other possibilities, just eliminates the ability to look at these things through a different lens.
Right. Well, I'd say that if you tell your kid that the fact they feel uncomfortable with society's roles for them and the way their body is changing means that they have gender dysphoria, they are a transgender kid, and they need to go to the gender clinic and get going with medicalization, you are telling them that there is something wrong with them. That is telling your kid that there is something wrong with them. If you need powerful medicines and surgery, there's something wrong with you, right? Like, we used to tell gay kids it gets better, right? Like, I know things are rough now, but it gets better. Your life's going to get better. And now we tell them there's something wrong with you, but it's cool because the doctors can fix it. Let's go.
And the irony is, we'll hear several times in this hearing, just to all the trans kids and families out there, you're beautiful and you're fine just the way you are. It's like, no,
except
you
that
don't
we're
understand
going to cut you up.
Yeah, you don't understand the nature of the debate here. The debate here is over that they're not fine the way they are, and we've got to surgerize them.
Yeah.
Okay.
Suicidality is a debilitating way to endure adolescence. A suicide attempt is a traumatic interruption in a young person's life. Let's be clear. Pediatricians know that life-saving means life-sustaining. When trans youth receive the standard of care, they thrive. They develop talents, they discover their strengths, and they get to be who they deserve to be.
Okay, so she finishes that by planting the idea that all pediatricians agree with this mode of therapy. They all know that the evidence is strong, that it works, and that kids will thrive on it. And having looked at the evidence and looked at different perspectives, listened to the lives of detransitioners, I don't think that I can agree with that statement.
Well, no, and that has not been my experience. Like I mentioned, my first transgender patient never went to college, never learned a trade, just was working one minimum wage job after another. And that has been much more the case. I've had one of my patients who medically transitioned who went to college. The majority of them have not. So it just doesn't go with my personal experience, which isn't huge numbers, but I am not seeing these kids like they medicalize and now they're thriving and they're expressing themselves and they're so happy. That's just not, hasn't been my experience.
Okay, let's keep.
Thank you. Kevin, I wanted to know why CDC took almost 5 years to implement the legislation and now we're reauthorizing it. But I think you're going to have to maybe answer that question for someone else, but at least get it on the record. Thanks
Okay.
for being here.
Yeah, we'll have the
Thank you
chance
to
where we
you.
can do it
I
and
yield
guide it
back,
moving
Mr.
forward.
Chairman.
Just to clarify, the bill does not ban treatment for precocious puberty, which the ranking member just alluded to. So a recent report found that the number of clinics in the United States focused on providing puberty blockers, hormone therapies, and surgeries for gender affirming care has grown from just a few to more than 100 as of February 2023. Dr. Grossman, in your written testimony, you mentioned how certain European countries have decided to take a more cautious approach and significantly limit the use of puberty blockers and hormone therapies to treat gender-related conditions in minors. Is the United States an outlier?
Well, it's certainly, yes, more and more becoming so. I just want to take one moment because this is really bothering me. Representative Issue, I'm sorry if I'm mispronouncing
That's
your
right.
name. Representative, you are very confused about something. When
I'm sorry, we'll just spin.
yes, Representative, I'd like to clarify something for you.
You can clarify it to me. Clarify it to me.
Yes, precocious puberty is a medical condition. It's a condition in which the child
What's that?
has
I'm sorry, would you, could
Spoke
you
to
spin
me
the clock just
directly,
like?
Mr. Chairman. You can't
Yeah.
characterize me.
Okay, you can't characterize with the way that she's,
Oh,
her
okay,
question, what she's asked. So if you just respond to
Okay, I'm
the
sorry.
chair who's
Yes.
asking the question.
Okay. The point is that precocious puberty, which we've treated with blockers for decades, and is approved by the FDA for that use, that is a medical disorder. That is a disorder in which the child has abnormal hormone levels circulating that causes their bodies to prematurely enter puberty. We do not want that to happen. We're talking about an experimental use of these agents in children that are completely healthy. They have no medical disorder. So we are artificially blocking a biological process, a natural process called puberty. Puberty is not a disorder. We need to go through puberty in order to reach adulthood. Every system of the body, the brain included, needs to go through puberty to reach adulthood. And what we are doing in gender affirming care is stopping that natural organic process and blocking it. And then shortly thereafter, in most cases, over 90% of cases, administering the hormones of the opposite sex so that the child will go through a synthetic puberty, not the organic puberty,
Thank
but
you.
a synthetic puberty. Okay,
Thank
I'm
you.
sorry.
She does a good job of explaining that there, particularly where there's, precocious puberty, there's something wrong organically, medically with the patient that has altered their hormone levels, put them in a state that they're not supposed to be in at a particular time of their development. So there's something you can identify and address very particularly. And that's very different from gender dysphoric patients.
Yes.
Is there a blood test? Is there an MRI? Is there any physical test where you can distinguish a patient that will benefit from these therapies?
No, that's one of the big problems with gender medicine is there is no blood test, there is no brain scan, there is no detailed questionnaire where you can go through it and if they score X, then you know. We really don't know which kids, if you have small children who are gender dysphoric, we don't have a good way to determine which ones are going to persist and which ones are going to desist, which is why the Dutch limited at first. At first, they limited their unusual treatment to just those kids who ticked all those boxes because they were trying very hard to avoid false positives.
Well, looking at the debate online, I've had people say, "Oh, no, there's a researcher who did some MRIs, and the trans people, the trans men, had the brain pattern of men, even though they were biologically female, and the opposite for women." So
Right.
we know that there's a way to do that, but I never hear that scan being cited
No.
as part of the diagnostic workup.
The thing is that every time, if you look at the brain scan studies, they're either not controlling for the administration of hormones. So, taking estrogen for years might change, the way your brain looks on the inside, and taking testosterone might change the way your brain looks. But mostly, they're not controlling for sexual orientation. Usually, if you control for sexual orientation, all of the differences that have been attributed to being trans are actually more likely to be from homosexuality.
All right, well, let's go on to our next one.
Ask me about the European countries.
I asked you if the United States was an outlier.
Absolutely. The United
Okay,
States and Canada
Thank you.
are
And would you speak to what the data tells us about the long-term impacts of these medical interventions?
So that's the thing. You see, this until recently was an extremely rare condition. It was so rare that when I went to medical school decades ago, I never expected to see one case in my life. That's how rare it was. And now that's all I do. So you see, in the past 10 years or so, specifically since maybe 2015, there's been an explosion of cases, an absolute tsunami of cases. And the question is, why is that? And those cases are very different than previous cases. This is a new population. The prior gender dysphoric cases that we studied were mostly boys.
Okay. Yes, thank you. I wanted to get to girls too, because I mentioned my concern about the mental health crisis for young girls. And over your career, would you speak to how patients experiencing gender dysphoria changed in the number and characteristics, and also speak to the long-term impacts for these medical?
Okay, so what I wanted to say is that when we speak about long-term, we don't have the data yet, because this is a new population called ROGD, Rapid Onset Gender Dysphoria. And we are just studying them now. It's a new demographic, mostly girls, but lots of boys as well. My practice is 50% boys. These are kids who have a lot of previous mental health conditions.
Okay. Thank you, Dr. Grossman. Thank you. I'm going to have to cut it off there, because I heard my colleagues say that this should be a private decision between.
Okay, so before she gets into the politics part of it, what do you, any comment on her invoking this idea that we're seeing something new here in this ROGD population? What is that? I
think she's right. I mean, if you look at the DSM, I think it's the DSM 3 and 4, gender dysphoria was a condition that occurred in, I think, 2 out of 10,000. Like, it was vanishingly rare. And it was primarily boys or middle-aged men. It was primarily male. And there were 2 groups. There were young boys, and then there were middle-aged men. And there were, there've always been some females, but mostly, like 3/4, almost 2/3 to 3/4 male. And then in the last 10 years, and it really started to take off after 2015, there's been a new population where the sex ratio has been flipped. Now it's 2/3 to 3/4 female. And these are females who had no apparent gender issues at age 3, 4, 5. And then at the beginning of puberty or in puberty, usually after spending a lot of time online and in a context of other friends with similar issues, they decide that the solution for all their problems is that they're trans. That is a phenomenon that many different clinicians have recognized. Lisa Littman published a paper in PLOS 1, and evoked a firestorm of response, which I'm sure you've already covered. But yeah, so I mean, you could just see McNamara rolling her eyes when Dr. Grossman says ROGD.
GD. And that was where we got a really good taste of how activists can influence the normal mechanisms of academic review and publication to build our body of evidence from which we try to operate our medical practice on, because they were able to influence the journal to have it retract and then correct and modify, but it eventually allowed then activists to say, oh, that article's been discredited. It was discredited.
It's been debunked. And it's like, no, really, it has not been debunked. They changed a couple sentences just to keep clear. You know, this was, she was talking to the parents of these patients. But in pediatrics, there's a long history of studying talking to the parents to figure out what's going on with the kids.
Yeah. Well, and I'm a member of a Facebook group of parents of ROGD kids. Mm-hmm. And they'll just tell you, like, this whole concept of dysphoria with their gender did not exist until they were on Tumblr or until they got a particular social group. There's always this social aspect of it. But then they'll say, but their kid now tells us that they've always felt this way.
Right. They sort of like retrospectively change their own history. Yeah. But recently, Springer has actually retracted a paper written by Dr. Michael Bailey and a mom from a group that is a group of parents of ROGD kids, where they were publishing accounts. I mean, it was a similar thing. It was based on information from the parents, and so it has the limitations of getting information from the parents about the kids. But I think it was 6,500. Like, it was a large number. Mm-hmm. And once again, like, it got published, and then there was a firestorm of protest. And they not only wanted it retracted, they wanted Ken Zucker fired for agreeing to publish it.
This is
and they
his
had
journal?
a letter. Yeah, this is his journal, a journal of what is that? Marriage and sexual.
Yeah.
And so they had a letter, and 100 academics signed it saying Ken Zucker should be fired for publishing this horrible, terrible, no good, very bad paper that talks about this horrible debunked notion of ROGD. And we all know it's nonsense, and you can't publish anything like that. That means you're not serious, and he should be fired. And so then actually I was involved in an effort to make a counter letter, and we got almost 2,000 academics to sign it and say, no, Dr. Zucker is doing his job, and that's fine. Mm-hmm. And so that's a good thing. Dr. Zucker didn't lose his job, but they still retracted the paper on this weird technicality, saying that because the people who filled out the form, and, to be perfectly transparent, it was a form that this group was using to vet the parents, right? Because whenever you're in a group with such a heterodox look at the world, you're a little paranoid that you're going to be infiltrated by people who are pretending to be part of your group so that they can then expose you to the world, dox people, all that kind of stuff. So they had a questionnaire that they sent to any people who were wanting to join their group, like someone wanting to join that Facebook group. And then they had all of this data, from people that ended up being, yes, members of the group. And so they thought we're legit. And Michael Bailey talked to a mom that was an organizer of this group and saw a little presentation he gave. And he's like, that's really good data. We should publish that. And she said, well, I'm not an academic. I don't know. And he's like, well, I'm an academic. And he went to his IRB for his institution. And he said, again, he's an older guy. He's like, back in the 80s, we could get retroactive IRB approval for things like this, but they were like, yeah, it looks good to us, but no, we're not gonna give you retroactive IRB approval. And the technicality that they used to retract the paper is that when the people did this, they signed a consent saying it's okay to use my anonymized data to publish on your website. But it didn't say it's okay to use my anonymized data for a medical journal article. And yet, if you're going to say that's the standard for publication, then every one of Jack Turbin's articles, data mining the 2015 USTS, should be pulled, because they didn't ask people, can we use your answers for medical journals. That was developed as a political lobbying tool. That was not a medical research survey.
Yeah.
And you
And
know, we
if
can
you
get
guys
into
aren't
that.
familiar with Jack Turbin, he's a gender affirming doctor that you'll find active on Twitter quite a bit, who kind of made a name for himself for taking this one particular survey and just pumping out paper after paper by
Just
digging
running it
into the data.
through the data software,
And there's
torturing the
also
data
so
until it
many
speaks.
problems with how that data was collected, the nature of the survey, the lack of controls against duplicate answers, the bias involved in where the survey was put. So you're absolutely right. It's a double standard.
Yeah.
But okay, well, that's the ongoing
Anyway,
debate. Now,
ROGD, boogeyman.
yeah, so ROGD, and it's toxic. They need to get rid of ROGD as a concept because that is the data point which points to social contagion.
Right. There's detransitioners and there's ROGD. If detransitioners exist, then it can't be eternal, immutable. And if it's ROGD, it's not there forever.
Inherent. Yeah, it's potentially socially transmitted. Okay, so let's keep going.
Parents, teachers, and parents, children, and doctors, that we should protect parent rights, and that Republicans are putting politics between children, parents, and the doctor. The truth is, parents are being removed from their children's doctor's offices, and kids are being taken from their parents and their homes. It's making it us versus them. That is my fundamental concern. I yield back.
Thank you.
Is that true, or is that an overstatement?
It depends on where you are. If I mean, the story of I'm bad at names. Gloria Martinez, I believe, is the woman's name. I met her in Southern California last October. Yeah. Wow, so much has happened. So the AAP meeting in Anaheim, California, we had a little demonstration, and she stood up and boxed and she shared her story. She is an immigrant. Her daughter had a lot of mental health issues. She adopted a transgender identity. She was socially transitioned at school. Mom was unaware. And then social services got involved because the mom was not, but the thing is, a lot of it was translation issues. The mom really just didn't understand what was going on, but they took her. They put her into foster care. They took the lady's daughter and they put her into a foster home. And then she started taking testosterone. And then she committed suicide by putting herself in front of a train.
Sure. But it points to
yes,
this
people are
notion
losing their children.
In addition to redefining disease, redefining, whether it's a problem in the mind or the body, we've seen also a redefinition of abuse, so that if you don't go along with these affirmative cares, well, then you're an abusive or neglectful parent. And so that then justifies child protective services or something coming in. That's, I think, something that we're seeing take a form as a possibility because we've seen it happen in Canada, where a father who did not support the transition of his child and refused to change pronouns was incarcerated, was put in jail or prison because there are laws in Canada that define that as a form of abuse. And so I think people in America see things like that happening, and they see a trajectory where we're changing the way we think about these things, that they don't want to go there. And that feeds into, I think, rhetoric like what we just saw.
Yeah.
The chair yields back. The chair now recognizes the ranking member of the full committee, Mr. Pallone, for 5 minutes for question.
Thank you, Mr. Chairman. I have to say I'm deeply disappointed in the partisan Children's Hospital GME legislation being considered today. It prescribes in very minute detail the types of care that must be prohibited in order to receive funding, and tells our healthcare providers, major medical associations, and patients that Republican members of Congress know better than them about what should be considered standards of care within our medical system. And that should scare us all, particularly when this program is designed to train the next generation of pediatricians and pediatric subspecialists. So my questions are of Dr. McNamara. I know that transgender people and those who advocate for the rights of transgender people are currently facing fear, intimidation, threats of violence, but I believe that we must speak out on their behalf and support them. And I want to say thank you to you today for doing so. Now, turning to my questions, if this bill were to become law, what would the impact be on pediatric care?
So I'm very privileged to sit next to two people who have shared details about the types of medical care that benefit patients who I've cared for in my career, people with sickle cell disease, premature babies. Many people here might not know what goes into that type of care, but I do. And it's not my specialty anymore. I have subspecialty training in adolescent medicine. But the experiences that I had in a NICU in the middle of the night, resuscitating preterm infants, counseling their parents, working with my colleagues, offering advanced treatments for sickle cell to children with crippling pain have forever shaped my training. I am an excellent clinical researcher because of my training as well. And I think that I am not the only person. You know, I spoke to so many of my colleagues about this testimony. Everyone expressed disbelief and regret that it would escalate this far. Everybody wants children to be healthy and safe, but their care and what they require to be healthy and safe is expert. We know what we're doing. We know how to do it really well. And all that we ask is that we be allowed to do it without any sort of legal interference.
She's very confident in what she does. You know, there's that old saying that it's a, it's a poor.
She's an adolescent doctor, and she's talking about resuscitating premature babies. What is she doing?
Well,
Like,
she
is it just like the
subspecialized in
baby is
adolescence.
like the sine qua non of pediatrics because they are so innocent and so pure and so unimpeachable. And so she's just going to keep going back to that emotional base of the babies. Won't somebody think about the babies?
Yeah. Well, it's a powerful rhetorical tool, as you mentioned. And
Yeah.
she's also an excellent researcher. She told us herself,
Yeah. Who has never referred anyone under the age of 18 for mastectomy. She said that in Florida.
Yeah, that was a difficult interview to sit through. This notion, though, that she talked to all her colleagues and they're all just in disbelief of that. It's like, well, yeah, I mentioned to all the people at the gender clinic that our area of practice is a threat there. Of course, they were afraid of that, but the guy who asked the question frames it as though we're restricting these, we're prevented from giving this care, and that narrative that they're preventing these hospitals from giving this care, it's loaded with the idea that care is already ethical, effective, and no different from any other type of care that we have. It's not in this experimental realm. We know it works and we know it works for a long time, and that is the debate that Dr.
Right.
Grossman said. That it's not settled science. It's an active debate.
Yeah.
Of which one side
On a
is being
global
suppressed.
stage.
Yeah, exactly. And then the second thing is that, let's say this bill does pass through. Well, that means that the hospitals are going to close down. No, it means that the hospitals will say, we can no longer offer this care. I'm sure some doctor is going to open a clinic right across the street and we'll just tell patients to go over there or something. It's lucrative.
The little baby's going to die. Like, if we can't keep doing our gender care, then all the baby's going to die because.
And those gender clinics will have to say, okay, well, we're going to have to confine our therapy now to this, talking psychotherapy that is still permitted and that does still allow us to have a billable event. And never mind the fact that it's also going to make them less liable to the subsequent lawsuits that are going to come about kids who were intervened in these irreversible ways.
Yeah.
All right, let's keep going. Now, I know this is long, so at any point, if you need to go on with your life, then just say, let's, break it off for another time.
Well, I want to see Crenshaw.
Yes,
questioning.
that's
How long
what I
does
want
it
to get
take
to too.
Yes.
So
Okay.
we
Let's let
can
them talk.
skip to that to make sure that we've covered it. Let's see what we got here. Boop, boop. All right. Okay, let's see here. This may have been his opening thing. Let me see where we are on that. Okay, actually, if I go here to Crenshaw, a statement.
Right, because you said he made his statement in the middle.
Yeah.
So is
and
this
then
when he's made his statement?
I'm trying to find the exact time.
Because it's, you know, once again, like I've never been a huge Dan Crenshaw fan, but he did a pretty good job here.
Let's see. This may have been
was-
what we
First,
first
want
did.
to thank my friend, Representative Schreier, for her great
Yeah, that's the
bipartisan
same
work
one
on
we
direct
already
primary
heard.
care.
If that's the case, then let's move to the next one.
So we gotta keep moving on till he gets to question. But yeah, he was well coached. His staff, you know, just like with the actual the text of the resolution,
Yeah.
his staff did a good job.
And he's able to speak extemporaneously pretty well on the subject. Gary Click in Ohio is another politician that just managed to really dig into the issue, and those Ohio hearings are phenomenal. Okay, so here we
to
go.
perform complex surgeries and inform the choices that patients and parents make. There actually are unique cases in which a baby is born with genetic disorders that cause truly ambiguous genitalia. This is a mix of male and female reproductive organs.
And thankfully, the bill excluded the restrictions from those cases, so that is not really
Those
relevant.
vanishingly rare cases.
But they're always brought up. What about the intersex?
It's always the edge case, yes.
Questions, Mr. Chairman? I'm willing to yield time to anybody on the panel. Mr. Crenshaw, I recognize.
Thank you, my colleague. Thank you to my colleague, and I do have a few questions. You know, I want to say a few things. First, we keep hearing this is a politicized issue. This is a manufactured culture war. I got to say, we aren't the ones who did that. We aren't the ones that came up with this radical new movement that is performing permanent physiological changes to children with no evidence of any benefits. We didn't start that. We're just trying to stop it because it's crazy. It's a contentious issue, which almost 70% of Americans oppose. So we are just saying here that taxpayer money shouldn't be used for it. That's all. This should not be that controversial of an issue. Questions are for Dr. McNamara. I just want to ask you, honestly, you're not concerned about the unknown effects of puberty blockers, hormones, and surgical interventions in kids, the long-term effects, not concerned about that?
Everything I've said here today comes from a place of deep honesty and conviction for the care that I provide and the community that I'm a part of.
You've said that we've cherry-picked data. How do you mean by what?
Did he answer that question? Did she answer the question?
She said that she believes. She believes.
We skipped
Everything
over
she
it, but
did.
if you
Everything
watch
she
this
did is
testimony,
from her love for her
Yeah.
community.
you hear several of the representatives treat her like a saint. Oh, I'm so glad that, and it's like the most emotional language praising her personally for giving voice to this thing. And it's like you can almost see a light shine down upon her, and she has the perfect pious expression that is, the culmination
Don't worry,
of it.
it's
was
about to
that
fall
response right
apart.
there.
Let's just play the tape.
How do you mean that?
So it is very unscientific and flawed to pick a single study or a single statistic and to discuss it in isolation.
Totally agree.
Medical experts are able to talk about all of the evidence as a whole.
Totally agree. So it's good to look at systematic reviews, right? That's the gold standard of evidence when you're trying to understand whether something works or whether it doesn't. So the British Journal of Medicine looked at 61 systematic reviews with the conclusion that, quote, there is great uncertainty about the effects of puberty blockers, cross-sex hormones, and surgeries in young people. Journal of Endocrine Society came up with the same conclusion. Even the American Academy of Pediatrics, they all cite the lack of evidence. And so here's the thing. If you're doing a therapy and it's, temporary, whatever, fine, maybe let's try it. Let's see if it works. But when you're talking about permanent physiological changes, do you not agree, just from an ethical standpoint, that you might want extremely strong evidence of the benefits? And there is no systematic review that states that there is strong evidence of benefits.
Sir, are you aware of how the quality evidence grading system works and how it's applied?
Yeah, we've read through it. That's why I'm citing these journals. So which journal says something different? We should have that debate. Tell me a journal that has done systematic reviews that cites different evidence, that cites strong evidence for benefits of these therapies.
I just love how she thinks she's got him. She's like, oh, do you know how, we can make low quality and even very low quality
Okie dokie.
recommendations, as though, she on the lofty, pedestal upon which she stands is going to deign to talk to this lowly, one-eyed politician. And the little smile that he gets is like, yeah, we know. But that's the thing is, like, when
Yeah.
somebody says systematic review, that's not like, oh, just another journal article. That's
Mhm.
not like, oh, a statement of policy by the American Academy of Pediatrics. You can't call
Right.
something a systematic review unless you apply these grade standards. And it's not just like, oh, we modified the grade standards. When you go and you look at the grade standards, they say you should not deviate from this protocol, because this protocol is set to discard all of the biases that normally get infused in. As soon as you deviate from these prescribed ways of scoring it, you're introducing your biases.
Yeah.
But when you read WPATH says we used a modified grade scoring system, and then
And
we're
the
not even going to
Delphi.
we're not even going to tell you what the scoring was. We created a new thing. But the thing is that whatever went into the modification is allowing you to insert your bias into how you're looking at it. And it totally is in line with what Gordon Guyot said, which is that you can call it consensus, you can call it whatever you want, just don't call it evidence-based, because
Right.
you violated that principle. So when he's saying, yeah, we looked at the reviews, that's because when you read a systematic review, the first part of it, it tells you about how they score it. And even when you look at the Endocrine Society's paper, they describe how they score it, and they use the same symbols that the grade society has that you use to indicate the strength and the level of evidence.
Right. Although it's sort of obscure because it's these little circles with plus
Yeah.
signs. They look like aspirins, and it's just
Yes.
really small. And it's just like, oh, this has one little circle, which means very low evidence.
Yes,
And then, oh, this one has
exactly.
two, which means low evidence. And they all have either one or two. And so you don't really, you have to like look at the footnote to figure out what it means, the little aspirins.
Exactly. So a few months ago, I made a little helpful diagram, which is basically taking the Endocrine Society's evidence, and because they have, okay, these are the
Color-coding it.
bullet points of their things. And so you're just like, okay, all of this, you can see the quality of all of it. And it's like all low quality or very low quality. The ones with the outline box, that's the ones where they gave a strong recommendation. So there's some where very low quality and yet a strong recommendation.
Strong recommendation. I know, it's
And that
amazing.
was the brilliant part of that British Medical Journal review about the fact that this is not settled science. There's a lot of debate, and they got the godfather of evidence-based medicine to say, there are perhaps some instances where you might have very low quality data and you would still make a strong recommendation, but those should be vanishingly rare.
Right.
And you cannot make a
And
strong
there were like 3 there at least. I can't
Yeah,
remember, but
exactly.
yeah. It's
So,
crazy.
all right, let's
Things are
keep going.
crazy. Keep going.
Good stuff.
The standards of care were developed based on extensive.
You're not telling me any journal. You're not telling me any study. Don't say
That's not
standards
what
of
it-
care.
Yeah. So
Tell me one.
the standards of care.
That's the standards of care.
Yes,
That's
standards of
not
care.
a journal. That's not a study. That's not an organization. That's not an institution. You're just saying words. Name one study. I'm out of time. I yield
And
back.
gentleman's time has expired.
All right, that is the clip that is making the rounds for sure.
Yeah, that's the clip that I saw before. So I wanted us to get to that because he's like, you're just saying words. Because I think there's a decent chance that she doesn't know what a systematic review of the evidence is. It's not a thing that
Really?
they teach. Oh yeah.
That can't be
It's-
true. She
No,
told
no,
me
no.
she's a good researcher. She said
No,
it
no, no,
herself.
no. She no. The thing is, Yale has like, you tell people like, where's the evidence for gender care? And they'll send you a link to this article on the Yale website called What We Know. Have you seen that one? What We Know About Gender Affirming Care. And it's presented as though it's a review of the evidence. They've got a table and everything. And it's exactly what we were talking about. It's cherry-picked studies. They're ignoring any studies that don't,
Right.
don't correlate to what they want. And that's Yale. And that's where she's from. She's a Yaley.
Now, in her defense, she does have formal training in research. Like if you look at her CV, and so she should not be a greenie at this. And number two, she is familiar with the fact that there can be low quality as a score for something for which it's impossible to do double-blinded, randomized controlled studies, and the number of studies and the number of patients may not add up. And so you may end up getting something that's low quality because of the definition of that category, and yet a society may still make a recommendation of it. But the factors of how severe is this recommendation, how life-changing, how irreversible it is, what is the nature of the disease for which it's applied, all of those inputs go into that formulation. And when you really dig into this, there's no way that there should be strong recommendations for these irreversible interventions in
Right.
something that we have a long track history of natural desistance.
Yeah, I mean, if
And
you're going to be sterilizing kids, you had better have rock solid evidence that that's the way to go. It's just, it seems rather basic. But the crazier it is, the stronger it seems. I don't know. Because the thing is, every parent who has bought into this, right? It's the whole chain of trust thing, right? So if the parent had the unhappy child and they went to their pediatrician and the pediatrician said, ah, yes, I've heard of this. There's a clinic for that. And they get referred to the clinic and the clinic says, your child has gender dysphoria and this is the treatment. And the parent says, okay, and they do the treatment. There is no stronger advocate for the correctness of that decision than the person who's already made that decision.
yes,
So there are representatives with kids who are being medicalized. There was a judge in California who ruled against a skeptical father in a divorce case, and she has a child who is being medicalized. I mean, it's such a conflict of interest.
yeah.
But like once you've signed up for it, what can you do but fight until your dying breath that
Otherwise,
you
you
did the
have
right
to
thing?
yes. Otherwise, you have to confront very gravely the consequences of what you consented to irreversibly change in your child.
What
And
have
that
I
is,
done? What have we done?
Yeah.
Oh my God. Yeah. It's, and you know, none of these aren't bad people. Like everybody feels like they're the good guy in this
Yeah.
situation. The gender doctors, like the ones that I talk to, they really feel like they're providing life-saving care. And the fact that the statistics don't add up just mean that we need to do more research. They are like so confident. Like you'll read it in the papers. They're like, well, this didn't really turn out, but we know that this is
Right.
life-saving care. And so we're just going to keep doing these studies until we get the results that we expect to get.
And the body count of the kids irreversibly harmed by this just keeps growing. Crenshaw does have one more appearance that actually is a decent metaphor that he brings up that I'd like to make sure we cover.
Okay. I don't know. I don't think I saw that.
It happens at, it hasn't been memified, but it happens at 1 minute or 1 hour and 12 minutes. So let me see if I can find that. There really is a lot of good things to listen to. So I'm going to take my edit of this that has all of it, and I'll just post it as an isolated video so people can review it if they want to.
Make a few more points, and I want to run everyone through this thought experiment. So you know, my daughter's going to grow up with a father with one eye, and at some point she might say, you know, I want one eye, right? I identify as somebody with one eyeball, which, by the way, is far less important than your gender, just physiologically speaking. And so if I take her to the doctor and I say, can you just enucleate that eye for us because she identifies as a one eye, she wants to be just like her dad. What would the doctor say? They'd say, you're crazy and I'm going to have you arrested. That's what they should say. And this is for a physiological intervention that is far less important than your actual gender and your reproductive organs. Like, we have to stop this madness. This has gone too far. You know, I asked before about what evidence is there that there's benefit for these so-called standards of care. I mean, anyone can say that they have a standard of care, but it has to be based on some kind of evidence and research. And when you've done systematic reviews, which is, again, is the gold standard for how you come to a conclusion within the scientific community, systematic reviews of 61 other systematic reviews, and you find little to no evidence that there's benefits for this, maybe you just press pause maybe you just press pause. Because if we're doing permanent physiological interventions to children that have permanently disfiguring them for some hope of a benefit that is not conclusive, then maybe we should press pause. Like, that's all we're saying. Press pause. And actually, that actually is even less than that. All we're saying is let's not put taxpayer money toward it. Right? This is no different than how this Congress deals with the Hyde Amendment. This is a controversial issue. Abortion is a controversial issue. And so we say, look, we disagree on this, so let's make sure we don't put taxpayer funding toward it. That's all this bill is. Let's not put taxpayer funding towards something that is so obviously unproven and contentious. Actually, I don't even think it's really not that contentious. 70% of Americans oppose it. So it's actually, the American people are pretty much on the side of not doing this, or at least pressing the pause button. Dr. Grossman, you're a child psychiatrist. Can you expand upon the profound lack of clinical reviews and the long-term impacts of these treatments, puberty blockers, hormones, and surgeries?
Well, yes, as I said, we don't have the kind of studies that we would like. And I think it's very important for people to understand that when we talk about standards of care and we talk about guidelines and all the various associations that have come out for gender affirming care and about politics and partisanshipness, those organizations themselves are rife with politics. They are permeated with politics.
Can you expand on that? Tell us how those activists have pressured dissenting voices in this
Well, yes,
field.
I just interviewed a number of doctors for my book, pediatricians, endocrinologists, who reported back to me on the fact that when they tried to speak up and have panel discussions or presentations that challenged gender affirming care at the American Academy of Pediatrics or at the Endocrine Society, they're simply not given that opportunity. Even people, who have written writing articles, the articles are turned down by a lot of journals. People have to understand that politics has medicine, unfortunately, is permeated with politics at this point. Now, ideally, we wouldn't be stepping in. Who wants the government stepping in between doctors and parents and children? Of course, we ideally don't want that. But when there's something that is so wrong that's going on, then I think we have to.
All right. I think that of all the things in this debate, that's a pretty important point, is that, we think that these professional societies are impartial, they're guided only by pure science, and that there's no ideological or political dimension to it. I don't know that I would use the word political, other than just that there's maybe some infighting of authority within the institution itself. I don't think people are lining up along Republican or Democrat lines within the professional societies, but there's certainly this ideological component about how you define disease, how you define gender, and how you look at what is abuse, what is disease, and the things that we've talked about here.
Yeah.
What do you think about his metaphor with the eye?
I think it's a good metaphor. I mean, it's especially a good metaphor for a guy with one eye to make.
Yeah.
I think that his eye was injured in some sort of I think he was being unwise with a firearm.
Oh, really?
I think that's the story. Yeah, but I could be wrong on that. Anyway, but I do think that's an excellent metaphor. And there really are cases of people who identify as having one leg and who have gotten doctors to surgically remove a leg.
Yeah.
And sometimes if you're arguing with people about, gender affirming care, they'll say, well, if we don't do it in the hospital, they'll do it themselves, Yeah. So definitely, that is a thing.
And it's funny that he uses that example, but Dr. McNamara says standard of care whenever he says, what is the evidence, standards of care? And then you look at WPATH's 8th version of their standard of care, and they include this gender dysphoria stuff, but there's also now a chapter on eunuchs.
I know.
So when she says standard of care, we're carrying over this idea that not only is trans or non-binary or gender expansive a gender identity, but also eunuch is a gender identity. And if
Eunuch
we're
is a
going to
gender
just,
identity. I have a whole chapter on it with links to the Eunuch Archives, which is basically a fetish site. It's got pornographic stories about young men being castrated against their will. I actually clicked the link once. I regret it.
the FBI will be after you soon.
Sorry, yeah, so no, don't do it. But the thing is,
That's not how you do medicine.
The
You don't-
standards of care was released. Like, I had access to the standards of care, maybe through a leak, I can't remember, in December. They were supposed to come out in January. And they had an ethics chapter and they had the eunuch chapter. And when they finally came out with the standards of care, which was months later than they said they were going to, they dropped the ethics chapter and they kept the eunuch chapter. And I was like, okay, WPATH has fallen. It has completely fallen to the activists, because there have always been people who are trying to do the right thing, people who are serious scientists, people like Ken Zucker, people like Stephen Levine, who are in WPATH, Rita Kierta Caltialo. And when they chose to keep the eunuch chapter and drop the ethics chapter, that's when I was like, yeah, they're lost. They've lost their way. I mean, they were never very serious. They've always sort of identified as a professional organization, but that was just the final nail in the coffin for me. How can you take them seriously when that's what they choose? And they removed all age limits for all pediatric. It was going to say 17 for vaginoplasty and 15 for mastectomy, even though mastectomies are happening on 12 and 13-year-olds, at least in California. And then they removed those because they decided that if they had an age limit in there, I think this is what happened. They decided that if they had an age limit in there, then somebody could be sued for doing a mastectomy on a 12, 13, or 14-year-old, which has already happened. Actually, both the mastectomies and the lawsuit have already happened for mastectomies done. There's a lawsuit right now in California with a girl who was started on testosterone at age 12 and had her breast removed a month after her 13th birthday.
Wow.
By Kaiser.
Well, those lawsuits need to be brought to bear so that the consequences of these can really be sorted out on economic terms, if nothing else. And that's
California,
unfortunately the way it happens. I mean, that's when we've had certain medical and other types of interventions being done in the past. It's really once the lawsuits started happening that people realized that the risks is just not worth it. And
right. Yeah.
if
we can't get the medical societies, to take a look at the evidence, then there's only a couple other ways to get at it. And one is via legislation, which I'm not fond of, but my friend Jenya said, if the medical societies won't pump the brakes, then the legislators are going to slam the brakes on gender transition. And it's just what you were describing was my experience. I tried to publish an op-ed, basically an op-ed. It's called Pediatrics Perspectives, in the journal Pediatrics, which is the official journal of the American Academy of Pediatrics. I wrote to Dr. Lewis First, who is the editor of that journal, complaining that they were promoting Jack Turbin's terrible, no good, very bad paper as their #1 paper of the year. And I was like, how can you possibly promote this as your #1 paper of the year? And he wrote back and he's like, well, it's not really based on quality. It was based on engagement. It got the most clicks. So we called it, it's #1 because of its engagement. And I'm like, no, I see you on the video talking about this being groundbreaking, blah, blah, blah. And he's like, well, if you feel differently, you should submit your own opinion, like a pediatrics perspective. And I looked it up. And it's basically a way for a practicing pediatrician to just say, this is my experience. And I wrote it, but then, as I've already mentioned, it was sent out to gender doctors for review, and they were just utterly shocked at what I was saying, and it didn't get anywhere. So yeah, if you have the wrong opinion, you can't get anywhere. You can't get published anywhere other than possibly Ken Zucker's journal.
Yeah, and even that is not a sure thing anymore, as we've learned in the last couple of weeks.
Right, yeah, then you can get retracted.
Yeah. When Dr. Grossman was talking about how dissenting or voices that offer a different perspective on this have been shut out from these things, I thought she was talking about you, and when she said, "I've talked to some of these doctors," I'm like, that sounds like Dr. Mason's
Actually,
experience.
she hasn't talked to me. That I haven't
Really?
talked to her for her book. No.
All right. Well,
Haven't had any conversations with her. But yeah, I mean, every year I submit a resolution to the annual leadership forum asking the American Academy of Pediatrics to conduct a systematic review of the evidence. And every year they come up with new ways to bury my resolution. This year I submitted it with 23 co-authors. So it was 23 and me, which is kind of fun. 23 fellows of the American Academy of Pediatrics who were willing to co-sign this resolution saying, you know, we would like the American Academy of Pediatrics to do a systematic review of the evidence. However, I've been unsuccessful getting anybody who is a member of leadership to co-sponsor it. And without that, it's going to die a very quiet death.
yeah, and that's where the politics come into play, where if you sponsor something that is unpopular, then you put your position at risk. The activists have a way of making you pay a price. People's professional credentials, their standing in the community get threatened.
Yes.
And it's a form of bias that, we're learning can have real consequences just in the way that our academic institutions work. Now, I know that you are affiliated with SEGM, and
Yes.
I just want to give you a chance to talk to, point people to where they can go if they want to learn more about really approaching this issue with evidence-based at the heart of it, with really trying to understand more and talk more conversantly about a better way to look at these things. Where would you point?
Yeah. I was just checking, making sure I had the website right. Okay, so SEGM is the Society for Evidence-Based Gender Medicine, and I believe we formed in 2019, so we've been around for a while. We're not a membership organization. We're more of a loose affiliation, and we promote evidence in this. So we'll do things like sponsor research. We are actually sponsoring some systematic reviews of the evidence done by personnel at McMaster University, which is the home of evidence-based medicine.
Oh, really? You're getting McMaster University to...
Yeah, we're getting McMaster
That's
University
good.
people to do systematic reviews of the evidence for...
They're not going to back out at the last minute like so many other things seem to happen.
Well, it's not done till it's done, but it's in process. And yeah, there you go. And that's our website. And so that is segm.org, SEGM.org. And homepage, and it just shows the rotating graphs of the crazy increase in the numbers of young people identifying as transgender. That's Sweden there, but it rotates.
Yeah.
And there's the United Kingdom.
There's other pictures of or other clips of McNamara being asked, what's the issue? Why are we getting such a surge in patients? He's like, well, I wouldn't characterize it as a surge of patients. The number of trans people has always been the same. It's just that people are more comfortable now.
Yeah, it's just people more. And then they show you the graph of left-handedness.
Yes.
That has been like cherry picked, where it was artificially driven down, and then they removed that and allowed it to come back up.
But it's just like our OGD. You can't admit it, because then if you admitted that there was a surge, you'd have to admit a social contagion component.
Right.
And so it's one of those facts that cannot be seen.
Right. We shall not speak of it. But I want to also point out, so sorry.
Mm-hmm. Go ahead. Go right ahead.
We're looking at the homepage, and then next to it says Spotlight.
Okay.
If a person wants to learn all about gender and what's going on, just go to that page. They're in sort of reverse chronological order, so you might want to scroll down a bit and then just start reading these articles. These articles are amazing. I can say that because I'm not the one that writes them. They're so good. I mean, they go through such vetting. You wouldn't believe it. So many smart people have looked at these. If it's in one of these articles, I'll bet my life on it. Like, because one time we had a reference, like we referenced a paper when we should have referenced the paper that the paper referenced, if that makes any sense. Like we inaccurately attributed a fact, and we've been drug over the coals, for that. So like, to that level of detail, to the
Yeah, that's
references,
funny.
etc.
You guys can't do that, but they can cite the Unic archive.
Yeah,
that's
yeah,
fine.
exactly. They could link you to the porn site. So yeah, they go back because we've been writing these for a while. But
Yeah.
each of those, if you click on the headline, it'll take you to a full page. But what's really nice is like just reading the headlines kind of gives you an education
Yeah.
in what's been going on.
Yeah,
And
you can
then
kind of
just,
see how the debate has evolved.
yeah, yeah. And it just, those are really good. I don't think they get enough attention. I really want to recommend people work on those. And then the studies page is good. It needs to have more articles, but like if you
Really?
click on any of those, you could, yeah, show them how it works. Like click on one.
Okay, so
Well,
yeah,
no,
so
wait.
each of these categories you can
Yeah.
expand. So if you're like, I want to know the data on, desistance, transition, and regret, and let's look at child onset gender dysphoria, and there's just the relevant studies. This is a great resource if you want to
Yeah.
dig into the
And then if you
data
see that
behind it.
cute little magnifying glass, that means that there's a SEGM summary
Analysis?
there,
Oh,
analysis.
okay.
Yeah. So
Oh, okay. So that makes it easier to digest what the significance of each of the papers is.
right. So
Oh, that's
there's
great.
there's a whole, yeah, it's a whole thing. You can learn a lot at
Yeah.
segm.org.
And I think that they have a
donate.
Twitter account as well that is also
Yes.
kind of, it's an easy way to tap into the new things that are happening there. The other thing
Yeah.
that I always like to point people to is the podcast by Sasha Ayad and
Stella
Stella
O'Malley.
O'Malley. Exactly. It's the Gender Wider Lens podcast. And I
Gender, a
believe,
wider lens. It's an
I believe you
education. If
showed
you
up
like to
there.
get your information in your ears,
Yes,
that's the
exactly.
way to get it. And yeah, I was
So-
a guest there a couple weeks ago
Yeah, with Dr. Levine, if I recall
with
correctly.
Dr. Levine. It was
So
lovely.
this debate hit the screen, and I was so happy that you were able to take a little bit of time to talk on it. Something I've been trying to get you
Dark
on
now.
in the past. It is dark now. Was to talk about the paper that you co-authored with Dr. Levine about the lack of evidence and how the protocols have been manifesting. So I hope to be able to get you back for that at one point. I don't want to keep you too much
Someday.
longer. You've been so generous with your time. Thank you so much. Any parting comments beyond that?
No, just anybody
All right.
watching this, check out the website.
Very good. All right.
Okay.
So until some next crazy thing happens or I can snatch you for a review of your paper, then this has been Talk on Things and Stuff. Take care.
Okay.